and participate various research work in medical field. And in this line, today we are launching our first program in preventive radiology titled Stratification of Non-Alcoholic Hepatic Liver Disease to be evaluated by ultrasound and the findings be correlated by other findings of other modalities. I thank Dr. Amarnath and Dr. Riju Matthew for conceptualizing this program, this idea, this concept about a year before. And today, with the help of Mindray India, we are going to participate in this research. In the coming 24 months, probably across India in more than 20 centers, we shall be conducting this research on a very good ultrasound technology, Resona I9, and we will be corroborating the findings with other modalities. And I think, and Dr. Bhushan will also agree with me, that I think by the end of this program, we shall be in a position to quantify, stratify, and determine what are the causes and how to prevent alcoholic and non-alcoholic liver steatosis. I thank all the faculty members who have taken time. I thank the Mindray who has contributed some 3.5 million Indian rupees for this particular project to be spent in next 2 years. And I thank all the committee members of Preventive Radiology of IRIA and Research Wing of IRIA to do this program. Thank you so very much. I congratulate you all. Thank you so very much, Rizo. Thank you so very much, Dr. Amar, Mr. Kamram, Mr. Rana, Mr. Jeff Wong, and everyone. Thank you so much. Jai Hind, Jai IRIA.
Thank you, Dr. Pushparaj Batelia, that was the president of the Indian Radiological and Imaging Association, who inaugurated this session. Now, next, I have to invite a dynamic, immediate past president of IRIA, who has been part of conceptualizing the preventive radiology, and it was launched last year, Professor Dr. Amarnath Chelladure, the professor of radiodiagnosis from the Stanley Medical College, Chennai. May I invite Professor Dr. Amarnath to give his address.
Respected Pushparaj Patele sir, President Indian Radiological and Imaging Association, Dr. Riju Matthew, our coordinator for the preventive radiology, Dr. Umesh Krishnamurthy, President-elect, officials of the Mindray, Jeff Wang, Ashwini Raina sir, and Ekambram, and all the faculties of today's session. First of all, I thank Mindray for supporting IRA in all the scientific events. And I am already happy that Mindray is now our scientific partner in the all the research activities with the IRA. And last year, with the help of Rijo, we have started the preventive radiology wing of IRA, where this NASH and other preventive radiology methods were started under IRA. And we are also started research wing of IRA, under which we are doing multicentric study, and that is approved by the IRA. And I am happy that under Resona I9 mission, we are doing this research throughout the country with multiple centers. And again, I thank Mindray for supporting our scientific research, and IRA will definitely support Mindray for their future help also. I thank Rijo for doing wonderful job on the preventive radiology. Definitely, this will be useful for the entire societies. Thank you again for starting this. Again, I thank Pushparaj sir for inaugurating this wonderful event. And in the next 2 years, we'll do multiple sessions throughout our country. We are going on site. And throughout India, we are going to do this preventive radiology workshop with Resona I9. Thank you again, Mindray and the IRA. Thank you. And all the best wishes.
Thank you, Professor Dr. Amarnath, immediate past president of Indian Radiological and Imaging Association.
Thank you.
I have got a short presentation for the next 10 minutes, and let me start with a video presentation.
Before that, I'll just introduce Dr. Rijo over here. Of course, this person over here needs absolutely no introduction. I mean, beyond, being chairman and chief radiologist at Insta Specialty Hospitals and Amma Scan Centers, and of course he's established. He's written a whole lot of articles and everything. But this person over here, we were just talking some time back. He's somebody who's so interested in doing new things and interested in pushing all the boundaries. He's conducted numerous sessions in the last year or so, and he's been at various posts in IRIA. He's been the national coordinator for IRIA Fetal Radiology and Subduction program, which has brought out exceptional results. And now he's the national coordinator for the Preventive Radiology program by IRIA. And definitely he's like a guiding light for all of us. So, thank you, sir, for, being here and being a guiding light. And hopefully we should go on to a lot of things. Thank you. So with that, sir will just give a presentation to us on the idea of preventive radiology and what our mission really is.
Thank you, Dr. Regis. Regis is co-chairing me with for this session. Regis and myself are the chairpersons and moderating the session. And Regis Chaubil is the national academic lead in charge of the NAFLD and NASH for preventive radiology. Can I request the technical team to play the video?
Hi, I'm Dr. Rijo Matthew. I'm the National Coordinator for the Preventive Radiology Program of Indian Radiological and Imaging Association. You may all wonder what preventive radiology is. You have heard about diagnostic radiology and interventional radiology. This is a new area that Indian Radiological and Imaging Association intends to explore in the new realm of preventive medicine, a focus that we would like to give on early detection of diseases with the help of imaging biomarkers and the strategy of risk stratification. We would like to focus on 4 areas primarily. The first one is non-alcoholic fatty liver disease and NASH, the non-alcoholic steatohepatitis. The second area, risk stratification of coronary artery disease and vascular health. Third area is cancer screening with multimodality approach. And the fourth is the screening with imaging biomarkers for endocrine diseases like chronic kidney disease, chronic liver disease, chronic heart disease, etc. So these are the 4 areas the Preventive Radiology program intends to focus upon. As part of this initiative, I'm happy to announce that we have partnered with Mindray for a multicentric study on their sonography technology for the quantification of liver fibrosis. There will be a skill enhancement program in 12 states in India, which will be carried out in the next 2 years. This multicentric study will involve a minimum of 10 centers on the liver elastography, the validation with comparison of shear wave elastography with Fibroscan or VCTE, and MR elastography and biopsy in some cases. So this is an elaborate project and one of its kind. I would like to invite each one of you, all the members of Indian Radiological and Imaging Association, to join hands with the IRIA Preventive Radiology Wing to focus upon this entirely new area which opens new possibilities for radiologists. One of the emerging areas that we want to focus upon is a radiology OPD, a concept that we would like to promote as part of preventive radiology. To sum it up, I must say there are several projects, multicentric studies and skill enhancement programs planned as part of the Preventive Radiology program. The Preventive Radiology program will focus on risk stratification, imaging biomarkers, and the radiologist's role in the new era as a primary physician focusing on radiology OPDs, where the radiologist will directly answer queries of the patients and also of the consultants in helping them form a multimodality imaging algorithm for prevention and treatment of diseases. Once again, I welcome each one of you to be a part of this unique project, which will be a landmark project of Indian Radiological and Imaging Association. Thank you very much.
So I think I have explained the 4 core areas that preventive radiology intends to explore. So this new terminology of preventive radiology, apart from the diagnostic and interventional radiology, is something that radiologists has to explore and ascertain in the new era of technology medicine. Why we have to do that is every country has to go through this. Every country become from the developing to developed nation has to go through 5 stages of epidemiological transition. And the first one is usually the age of pestilence and famines, the malnutrition, infectious diseases, high infant and childhood mortality. All these things are more common. And then comes the age of receding pandemics, when the communicable diseases are less. It becomes the cardiovascular diseases that becomes more important. And in the next stage, it becomes the degenerative and human-based diseases with more mortality from the cardiovascular diseases, which surpasses the mortality from communicable diseases, leading to nearly 35 to 65% of all deaths. And then comes the age of delayed degenerative diseases, when cancer and CVD becomes the predominant cause of death. And then there is a declining trend in death rates, which the Western world before the COVID had. And the 5 stages of epidemiological transmission, the last one is age of inactivity and obesity, with declining physical activity and with slow epidemics of diabetes, hypertension, and lipid abnormalities. So India is a large socioeconomically diverse country, which presents evidence for all the 5 stages here. That is why 3 years ago, when we started the Samrakshan project, the perinatal mortality was focused. We said the states in the northern part of the country, especially the states like Rajasthan, Uttar Pradesh, Bihar, Chhattisgarh, and Madhya Pradesh and Odisha had a higher perinatal mortality, and that we have to focus on those states to reduce the perinatal deaths with a risk stratification strategy by using Dopplers to identify those mothers and babies who are at risk for preeclampsia and fetal growth restriction, both of them being the largest number of causes, causing nearly 70% of perinatal deaths subsequently, as prematurity is the main cause. But when you come to the other parts of the country, you can see the CVD rising, the diabetes, hypertension, slow epidemics rising, the cause of mortality being some of the slow epidemics. So we are a 1.4 billion country people, and can radiologists address this epidemiological transition in India? So I just want to share this slide, which shows if during Samrakshan, the period of Samrakshan, if I had told you that the perinatal mortality is very high in these states in the northern part. But if you look at the data on cardiovascular diseases, diabetes, hypertension, you will see the incidence is quite high in the southern and the western parts of the country. So that is because from a developing nation like ours, in the process of getting into a developed nation, we are going through these 5 stages of epidemiological transition. Every part of the country has got a different kind of disease burden, and we need to address them with a preventive radiology strategy or a preventive medicine strategy in that. So to optimize the unfulfilled potential of radiology with its expertise in imaging modalities, we have got a potential to lead the preventative and prognostic care at all levels of healthcare. And the possibilities in screening and early identification are endless. The possibility of radiology to provide link between early identification and clinical treatment are endless. So this is why the program has come into play, and a national committee was formed by IRIA for preventive radiology to create awareness, identity creation, and skill enhancement for the members to meet this futuristic challenge, to embrace the opportunity with better insights and experience. And a white paper was published last year on the various aspects. I'm not going into the detail. So, but the major focus of preventive radiology is healthy aging. So we are identification and evaluation of with the help of imaging biomarkers of various organs, systems, and diseases, and evidence-based integration with imaging biomarkers by using multimodality algorithms and multidisciplinary algorithms too. So the future is integrated diagnostics with pathomics, radiomics, and genomics. So pathology, genetics, and radiology are going to play a very important risk stratification strategy for the community, especially in the era of slow epidemics. If you really want to prevent some of them and increase the longevity of the population and bring in the aspects of healthy aging. So this is this is a logo that was accepted last year, and we have created a roadmap of activities, the creation of state level committees, and we are going ahead with all those. As part of that initiative, we have partnered with industry, with Mindray, for 12 programs in the next 2 years, especially on NAFLD and NASH, especially using the zone sonography technology and the liver fibrosis quantification using ultrasound elastography, especially the shear wave elastography. And along with that, there is a multicentric study that is being planned from at least 10 different centers. And we will be comparing the Fibroscan with the point shear wave, with the 2D shear wave, and MR elastography and biopsy in some cases. So this is the whole plan for that. And I hope I've given a very, very short, broader idea on what preventive radiology intends to focus upon. There will be more that will be coming up, and in the coming sessions, we will explore more of preventive radiology. Thank you very much.
I think that was a very good perspective of the things to come in the future, and yeah, fantastic introduction for that, sir. Thank you.
Rajesh, next we will have the innovation and new generation ultrasound at Mindray, a presentation by Mr. Agambram, the product manager from Mindray. May I invite Mr. Agambram to give his presentation.
Yeah, good evening. Thank you, Dr. Rijo. Good evening once again, doctors. This is in fact one of the most exciting day for us all in Mindray, and we are really honored for this privilege and confidence for the IRIA executive team. Let me thank the immediate past president, Dr. Amarnath, the current president, Dr. Pushparaj Batale, Dr. Rijo Matthew, the national coordinator for preventive radiology, and other senior members of IRIA, along with also the ethics and scientific committee for this landmark agreement. Our special thank goes to Dr. Nitin Chaubal and Rajesh Chaubal for their continued support and engagement and appreciation of our ZST technology. Also, our special thanks to our today's speakers, Dr. Praveen Nermalin, Dr. Bhushan Pandit, Dr. Srinivas Desai, and also Dr. Ritu Kashekar. So with this, let me have a brief discussion in the next few minutes about Mindray's innovation. Since inception of Mindray, we kept our focus in technology for the leadership in ultrasound imaging through innovation, and this made even more easier with our customer-centric focus. So if you look at from the point of technology and innovation and a customer-centric focus, we would like to also share with you where and who we are at this moment. Currently, we are present in about 190 countries. We have about 2,500 plus R&D engineers, and we are very, very happy to say more than 200 teaching hospitals in Europe are using our high-end ultrasound, along with the top 20 hospitals in the North America as well. Am I audible, doctors?
Yes, yes, very much. Please go ahead.
Thank you. Thank you. So to elaborate on our R&D, as we are talking about, we have about 8 centers around the world. Over 2,500 plus have been employed. The most important thing is we engage through more than 10% of our top line. That's, let's say, in about a year ago, that's about $300 million has been spent on the R&D activity. Currently, we have over 5,000 patents. That's one of the biggest in the healthcare field in the last few years. Coming into ultrasound, I think this is one technology called zone sonography, which is making the landmark changes. And I think you can see everybody talking around the world. It's called the zone sonography. It's available currently at the very premium level. And the most important thing is it's also very evolving. That means the technology is going to evolve as we progress. That's the most important thing. And if you look at from the point of how it is recognized, the one of the major agency called Frost & Sullivan, who are the leaders in market research, has stated this is the next industry standard. Also, this is at least 2 generations ahead of all the current technology available in ultrasound. Now, what is really zone sonography? In addition to the powerful architecture that it makes all the difference, the whole acquisition is completely different to whatever that is currently being practiced under the channel data processing. I'll go point by point. One is called the advanced acoustic acquisition, dynamic pixel imaging, sound speed compensation, and of course, the most important, the total recall imaging. So these are some of the first important differentiator. On the left side, you see what is called line-by-line imaging, which is currently practiced. And you see on the right side, the zone sonography, which has already covered the single scan, almost 1/3 of the line-by-line. This way, you're able to have more data at any given time. So it gives increased diagnostic confidence. Okay, this is also 10% faster. Now, one of the pillars of this is the advanced acoustic acquisition. To give you a small technical example, on the left side, you see an image which is acquired with line-by-line imaging like technology. On the right side, you see a faster acquisition where you can see better resolution overall and the temporal side. This is one of the very important. That's how you are able to see a better diagnostic information. Secondly, you are always used to putting a focal spot at any given time. If you don't see a very good image, on the very first one on the left side, you put a focal spot. If you don't see clearly, you apply a second focal spot. And this also not only reduces the frame rate, it also has certain limitation. Now, with the dynamic pixel focusing, you see the entire field. You can see here the image, what you want to see. At the same time, you also see something which is at the background, the bigger deer. So that is the biggest differentiator. You're able to see the entire image at any given time without a requirement of any change in the focal spots. These are the typical example how you see from the very homogeneous in terms of liver as well as in the bowel imaging. This is what is the actual outcome of our zone sonography technology. This is another very, very important thing. It has been assumed all transmission of ultrasound is fixed at 1,540 meters per second, which was decided around 30 to 35 years ago, which still continues. Of course, if any given time, if you want to improve the image quality, you'll have to start looking at other parameters. We have now come out with something called sound speed compensation. This is an image instead of 1,540 meters per second at the phantom, we have reduced it to 1,480 meters per second. You can really see it has been resolving much better and even at a deeper area. That's where you can able to make the difference. In a real clinical environment, if you have a very fatty patient coming into you, you can see a liver which is very hazy. And here you can able to see, in fact, the second image with much better lateral resolution, including the image at the diaphragm level as well. That is the biggest differentiator that you can able to bring out with the sound speed compensation, which is a part of zone sonography available in Resona series. This is a very, very important clinical engagement we are bringing out. Instead of zooming the image, we have a new feature called HD scope. You can see very tiny details without loss of images or pixelation. This is another important fact. Here in a real image, you are able to make out how it is able to bring you the different advantages from the clinical side, and also brings the diagnostic confidence, especially small areas. Now we are going into the specific subject, ultrasound elastography. This is a single biggest differentiator in the ultrasound. It is called ultra-wideband beam tracking. This is the biggest change that is happening as compared to all of the shear wave that has happened the last 3 years, in addition to the shear wave based other additional advantages. It really makes a lot of difference in ultra-wideband in terms of higher penetration, especially when you have a hard and deep-seated and large tumors. This is another landmark technology that has evolved called high frame rate shear wave elastography, which is one of the biggest problems. The moment you turn on the shear wave elastography, your frame rate falls. Here you can see that shear wave elastography with uniform images, very homogeneous images, as good as the normal 2D images. And that's how you're able to improve your diagnostic quantification as well here. It's also very sensitive for the motion sensitive detection as well. Now, You can see on the left side a regular shear wave elastography, and on the right side you can see the one which is the very high frame rate shear wave elastography, which has got less jerk. Obviously, this is going to bring a very smooth, consistent image as well as very sensitive to motion detection. This is a part and parcel of our high frame rate shear wave elastography. In addition to that, we are also employing the quality control, which gives you the reproducibility and repeatability. Now, if you go into the quality control, we have two quality control. The most important thing is called motion stability index, which helps you to able to see the patient respiration or patient transducer based movements not there. As a result of this, you can see all 5 stars green, and then you can start quantifying. Similarly, in terms of the reliability information, you have 3 different factors. One is called the reliability map. On the top, you can make sure that it is all green instead of purple areas. Then reliability index, which is quantified in numbers, it should be above 80%. And similarly, there should not be any of these kind of hollow areas. So as a result, your images will always be consistent, reproducible, and repeatable, no matter where it is made and who is doing it. And also, as a part of shear wave elastography, we are making things very simple by providing a straightforward report as soon as you complete the execution. This is something, which people have been, we are seeing a lot of people have been struggling. So this is very, very biggest, ease of way of doing shear wave elastography. These are some of the cutoff values we have established by doing multi-center collaboration in China, along with the gold standard of liver biopsy. So here you can see different levels of F1, F2 along with the values. We are also part of the SRU consensus by Dr. Richard Barr and other authors with respect to our shear wave elastography, of course. And we have all the documents to support multi-center studies or the actual users, including the white papers and clinical papers as well. In addition to that, on the Resona platform, we have also introduced a new feature called Hepatorin Index, which was supposed to be an offline function. Now it is available as an integrated screening tool, which is based on the brightness calculation ratio between liver and renal cortex index, which is happening with a single button within a matter of few seconds. Now, one of the most important thing, we have not only done a fantastic, improvement on the shear wave elastography in terms of accuracy and repeatability. We also extended for the whole body applications on the shear wave elastography, beginning with breast, which includes unique shell analysis, also on the MSK. Along with that, also we have now in cervix as well as in prostate. So it gives you a complete range of shear wave elastography in the same platform. That is the biggest advantage. Over and above that, we also have a very good biopsy called iNeedle, where you can be able to see the whole needle shaft in both convex and linear transducers. And we are very happy to say our Resona i9, which was introduced in 2021, has won the Best Design Award for 2021 in terms of the ergonomics and engineering, and for ease of use, and also for multiple other areas. These are the outcome of our technology and appreciation. Since the last couple of years, we are seeing more than 19 out of the top 20 hospitals in the North America is using our ultrasound systems. Also, around 200 teaching hospitals have patronized us, and they are also using our ultrasound. We will continue to collaborate across the world, being present in multiple locations, so that we are able to address to your needs. And we continue to also keep having a similar program like this with academic engagements, so that we are able to educate and make sure that it is very effectively used and it's available across the globe as well. So this is in my conclusion. We would like to very proudly say that we believe in better healthcare for all, and our mission of advanced medical technologies to make healthcare accessible as is our mission for everyone within Mindray. Thank you. That's a brief presentation from me. Thank you all.
Thank you, Mr. Egampuram. One of the unique features of the Mindray involvement in this project is you might have seen many industry players supporting the skill enhancement program, but here there is a difference. Mindray has supported the skill enhancement programs as well as the research, multicentric research studies, along with the professional associations in India. That's a very, very welcome move as far as India is concerned. 1.4 billion population, And we have got a lot of data to give to the world, this thing, rather than getting guidelines from the Western population without much involvement from our data. There is a lot of scope for us to provide our data and help to have a real good guidelines being created rather than being a biased or skewed ones that is coming from the Western world alone. So thank you, Mindray, for considering this research proposal of Indian Radiological and Imaging Association as part of IRIA Preventive Radiology. Now we are coming back into the scientific session. We have to now get to know that NAFLD, preventing NAFLD, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis, fatty liver. Is it a real problem in India? So this is some of the questions. Some of you may be really skeptical. Is it being hyped about? So what is the disease burden in India? A statistical analysis of liver diseases in India. A perspective will be given by Dr. Praveen Nermalin. He is the Chief Research Mentor at Amma Healthcare Research Gurukul as part of the Amma Center for Diagnosis and Preventive Medicine in Kochi. Dr. Praveen Nermalin is a master's in public health from Johns Hopkins, USA, and has been a research mentor for the last 20 years or more, and is into the research, has helped the IRIA in the Samrakshan project also. With that introduction, may I invite Dr. Praveen Nermalin to give his presentation.
Thank you. Just waiting for the slides. Nope, it's coming up. Are the slides visible?
No, not yet, not yet.
Not yet. So it's on its way. Maybe it's gone for a cup of coffee. Anyway, I was told to talk.
We can see that. We can see your screen.
You can see it, yes. So good evening and welcome to all of you. I was told that I should speak on the epidemiology or a statistical analysis of liver diseases in India. And I looked at the time and it was 10 minutes. And I sort of figured that if I have to cover the epidemiology of liver diseases in India in 10 minutes, I might have to imbibe some liver supplements myself, which might impede my ability to speak. So I thought I will limit myself to NAFLD, which is also a core focus of the preventive radiology program. So bear with me through this. Now, the Asia-Pacific region, just to bring you a little bit of perspective on whether we need to look at NAFLD in India, whether we need to be looking at liver diseases in India. Is that an exotic thing to look at in India when we have this huge burden of other public health problems? Dr. Rija spoke about the epidemiological transition, and we know we have a lot of other problems. Is liver an elitist problem, or is it something that has moved into a public health realm? So the Asia-Pacific region is home to more than half of the global population. And in 2015, it accounted for 62.6% of global deaths due to liver diseases, the Asia-Pacific region of which we are a part. 54.3% of global deaths due to cirrhosis, 72.7% of global deaths due to hepatocellular carcinoma, and over 2/3 of global burden of acute viral hepatitis. Now, these are estimates that are coming from the Global Health Estimates of 2015, a WHO-led project. Let's look at it in terms of deaths. And this image shows you the 3 to 6% of liver-related deaths are in India. The green ones are the sort of better off areas, and the red ones are the really bad off areas. And we can see that we are somewhere in between. India is somewhere in between with 3 to 6% of liver-related deaths. Now let's look at the India-specific epidemiology. NAFLD and other causes account for 10.9% of all deaths due to cirrhosis and other chronic liver diseases in India, and about 9.6% of all deaths due to liver cancer. So about 10% of deaths due to liver conditions or morbidities, conditions in the liver, is due to NAFLD. Now, the thing to consider here is that NAFLD, or when they categorize that cause from an epidemiological perspective, from a study perspective, they also club certain other factors into it, like drug-induced liver injuries, and some other factors. But those are all at a minor, at a much smaller proportion. So the major bulk of this is contributed by NAFLD. If you look at the prevalence of NAFLD, community-based studies using ultrasound, we have the prevalence from urban areas and from rural areas. And we can see that there is a large prevalence, even from several decades back, from 2007, we have about 18%. 2009, using ultrasound in urban areas, it jumped up to 32%. It could be possibly related to the fact that our ability to detect, improve, our ability to identify, improve, more quantitatively, more objective. If you look at rural areas, it was about 8.7% in 2010 and 30.7% in 2016. And this is from a paper that's published in 2020 in the Lancet. If you look at, again, these are all community-based studies and not hospital-based studies. Now, if you look at NAFLD on ultrasonography, 16.6% in Mumbai, 32% in Chennai, 49.8% in a prospective cohort in Thiruvananthapuram, Kerala, a couple of years back. Recent study, prospective study on a cohort of people that they followed up as part of another study, and they're continuing to follow up. And they found that 49.8% of adults had some sign of NAFLD on an ultrasound examination. It's a different point if all this 49.8%, that's nearly 1 in 2, all this 49.8% actually need a clinical intervention at that point of time. But they had some signs of NAFLD, and that's a high percentage. And that was published in the BMJ Open 2019. Hospital-based studies, you would expect that the prevalence of NAFLD will be higher in hospital-based studies because the target population are people who are coming with some sort of sign, some sort of symptom, some sort of complaint. And so you would expect that there would be a higher prevalence. And you saw that it was 25.3%, it's nearly 1/4 in 2012 and increasing. Liver biopsies in nearly half of the patients with NAFLD with increased aminotransferase concentrations had histologically confirmed NASH. This from India. Liver biopsies in nearly 50% of patients with NAFLD who had increased aminotransferase concentrations had histologically confirmed NASH, although most of them, 80 to 98%, almost all of them, most of them had only stage 1 or stage 2 changes. So keep that in mind, that you're seeing that even though they had only stage 1 or stage 2 changes, they had histologically confirmed changes. Cryptogenic cirrhosis, believed to be largely due to NAFLD progression, accounted for 15.8 to 48.8% of patients with cirrhosis. So you're seeing that there is a large, the point I'm bringing in is that these are not small numbers, and these are not numbers that proportions that we have to convert into actual numbers. We are talking about 1/3, 1/4, 1 in 2, huge numbers. Let's move from there to the risk factors. And I'm keeping it India specific. I'm not talking about global. I'm not talking about Asia specific. For the purpose of this talk, I'm keeping it India specific. Over the years, we have seen that increasing obesity, hypertension, diabetes mellitus have led to higher incidence and prevalence of NAFLD in India. There are about 69.2 million adults in India with type 2 diabetes mellitus, aged 20 to 70 years in 2015. A huge number, 69.2 million adults with diabetes mellitus, which is expected to increase to 123.5 million by 2040. And what's its relation with NAFLD? The prevalence of NAFLD is high in people with type 2 diabetes. It's been reported from as low as 10.5% to as high as 88%. And let's make a conservative estimate there and say it's about 50%. It's again 1 in 2. So 1 in 2 of people with type 2 diabetes might have NAFLD. If you translate that into numbers, we are talking about millions of people with diabetes mellitus that can have NAFLD. So the problem is not small. The problem is real. The problem is big. How about hypertension, which is another risk factor? And we see the prevalence of hypertension among urban adults. Jaipur, 1995, among men was 30%, women was 33%. In 2002, again, Jaipur, men was 36%, women was 37%. Rural Rajasthan, men was 24%, women was 17%. So you're looking at rates. You're looking at rates of the proportions of the risk factors that are high. They're running around the 1 in 4. They're running around the 1 in 3 ranges. And if you look at Mumbai, 1999, 44% of men, adult men, 45% of adult women were considered to have hypertension. So large number, nearly 1 in 2. Tirunelveli in Kerala, 31%, 36%. Chennai, the CURE study, 23.2% in men. The CURE study was both urban and rural. So slightly less, 23.2% in men, 17.1% in women. If you move from that to insulin resistance, which is another thing that is common in India, studies have shown that higher insulin resistance and hepatic triglycerides in India in comparison to other races, especially the Caucasian races, is higher in India compared to the Caucasian races, especially the US-based races, suggesting that Indians are much more prone or much more at risk to develop NAFLD. So we have risk factors of diabetes, we have risk factors of hypertension, huge numbers. Additionally, we also have a high proportion of insulin resistance. Insulin resistance has also been independently correlated with NAFLD regardless of adiposity. And the prevalence of insulin resistance in Asian Indians residing in India is as high as 55%. Can reach up to 55%. So it's a large number of insulin resistance. And that's a factor that has driven the prevalence or the incidence of diabetes mellitus in India as well. Insulin resistance. Hepatic triglycerides and plasma IL-6 concentrations were nearly twice higher in Asian Indians compared to white Caucasians. And the increase in hepatic triglycerides and IL-6 concentrations was associated with a higher prevalence of insulin resistance in Asian Indians compared to white Caucasians. I'm again pointing out that as a population, we seem to be carrying a much higher risk for NAFLD. And these are coming from published studies, what we can say as evidence-based literature, coming from published studies. If you look at obesity, the National Family Health Survey 4 had shown that obesity had nearly doubled in 2015-16 to 18.6% from 9.3% in 2005-6. The National Family Health Survey 5 is out. It's not yet complete, but it has shown a significant increase in the rates of obesity among both men and women. So we can see just about 1 in 5 males in 2015-16 having obesity, 1 in 5, just above 1 in 5 women 2015-16 having obesity. And National Family Health Survey was a national survey, urban and rural, a household survey, considered to be representative of the general population of India. And this is a document that is often quoted and used for policy making at the central level. Moving ahead from abdominal obesity or body mass index, let's look at the hepatic fat content of Asian Indians. And it's almost twice in amount for a similar body mass index when compared to white Caucasians. Hepatic fat content. It's almost twice for a similar body mass index. And that's important because from Chennai, from Dr. Mohan Center in Chennai, we had seen that we have evidence that Asian Indians develop diabetes mellitus. The incremental risk for diabetes mellitus in Asian Indians is higher at a lower body mass index compared to a normal Caucasian population, where 25 was considered overweight, more than 25. For Asian Indians, it went down to 23.1, or around that range. And they've shown that for every additional increase in the body mass index beyond 23.1, the incremental risk to develop diabetes mellitus was much higher. And so it led to a realignment of the body mass index categories for Asian Indians, where normal was no longer running up to 25. Normal was now shortened from around 18 point something to 23.1, around that range, as opposed to 18.1 to 25, which is a normal category. So the body mass index got recategorized, and we can see that hepatic fat content here is showing the same change. It's almost twice in amount for a similar body mass index when compared to white Caucasians. And an interesting aspect about NAFLD in India was that 11 to 32% of patients with NAFLD in India had a normal body mass index. So it was not only a condition of the obese. It was not only a condition of a high BMI, not just more than 30. We have to be looking at BMIs even less. So it's showing that the risk for developing NAFLD in India is quite different from the risk for developing NAFLD in a Caucasian population. The mean BMI in Indian patients with NAFLD is much lower than that's reported from the West. These are important small changes, and these are changes that are reflected and have been proven in the field of diabetes mellitus, and took the field of diabetes to a decade or more to reach this conclusion that there is a change and the incremental risk is different. Yet Dr. Yachnik's work from Pune, which showed the body fat of fetuses and how it affects diabetes mellitus. Dr. Mohan's work from Chennai, which showed incremental risk increases in body mass index, is much different from that compared to a Caucasian population. So we are seeing a similar aspect here in NAFLD also. Transaminases, the histological severity in Indians with NAFLD presenting to hepatologists with raised transaminases is milder in comparison to data from the West, even in stage 1, stage 2. You're seeing histological changes. So something is different. Is there a gene environmental factor there? Is there a genetic factor? Is there an environmental factor? To get into the details of that would take a lot of time, but keep it very brief. There is a higher phenotypic expression of the APOC3 gene polymorphism in India. And is that higher expression mediated by environmental factors? There are several theories running around it. It's something that has to be conclusively proven. But what we know is that there is this higher phenotypic expression of the APOC3 genetic polymorphism. What's driving that? Is there an environmental influence? Well, there are theories that are looking at the gut microbiome, and if a different bacterial flora in Indian patients makes them more prone to the development of NAFLD. Besides conditions like diabetes mellitus and the hypertension, obesity, and the underlying factors around it that are altering the expression of this particular genetic polymorphism, and thus leading to a higher risk for NAFLD in Indian population. So after this, now what does all this mean? It means that we have a large number of people potentially undiagnosed, potentially asymptomatic, potentially at a milder stage of the disease with NAFLD in India. Not all of them must necessarily reach the hepatologist at this particular stage, but we have a larger number. We have a larger number of people at risk to develop NAFLD. That's driven both by genetic polymorphisms, that's driven by environmental factors, that is driven by differences in hepatic triglycerides, insulin resistance, hepatic fat content, body mass index, transaminases, and the way that they are all acting. What does all this lead to? It leads us to a question that can we rely only on clinical and biochemical parameter values that are derived from a population that's showing a very markedly different clinical picture of NAFLD compared to what we see in our population? Are we justified in using those values alone for the clinical management here? And that's a question that I would leave you with. It's not a question that I'm going to elaborate on this particular session, but that's something that you need to think. If you're seeing that the characteristics in the Indian population are different, then are we justified in using those values to guide our clinical management? We see that we have a rapidly increasing prevalence of DM, HT, and METs in India, obesity and METs in the metabolic syndrome in India. There's no question about that. We have high insulin resistance. We have a possible genetic pathway. At a conservative estimate, we are seeing that 1 in 5 adults in India has changes suggestive of NAFL. Does not mean that all of them must go into some sort of a clinical intervention, but that it is there, that it might progress to a stage where they need a clinical intervention. So it's not a small problem. It is a problem that must be looked at. Biochemical tests which are being used, let's be pragmatic, let's be honest. They're not widely available. They're not easily accessible. Standardization remains an issue across most places. So can we rely on those results? Leave alone metros, leave alone tertiary care centers where these are possible. But when we have these huge numbers, can we rely only on biochemical tests? And that's if we use clinical scores which are available. There are clinical scores based on questionnaires that are available. Again, their effectiveness and standardization is questionable. So that's where radiology comes in, because you are able to quantitatively and objectively analyze what's happening. That can be a benchmark for you, not only for arriving at an initial diagnosis, when you put it in alignment with all other factors, not as a standalone, but it's also an objective measure, a benchmark that can be used to follow up. There's no ambiguity there. The imaging tells that it is there, whether it's a SWE, whether it's MR elastography, whichever modality that you are using, it tells you, gives you an objective picture that can be stored, that can be looked at later. It's relatively painless, non-invasive. There's a rapid turnaround time for reports. You have a trained workforce of around 17,000 radiologists in India that are capable of upscaling to do this on a routine basis. You have multimodal imaging pathways that can be used to triage. So you don't have to send all of this 1 in 5 patients to a hepatologist and then overwhelm them. Right? You can triage the absolutely necessary ones to reach them, the ones that really need their care. You can look at the milder ones and devise a strategy that can be used for preventing progression to a later stage. The modalities are there, and that's where ultrasound and imaging modalities come into the picture, because it's objective. You can use it to diagnose. You can use it to monitor progression as well. So moving ahead, preventive radiology. Do you have a caseload in India? Yes. Are there high-risk groups in India? Yes. Instrumentation available? Yes. Workforce that can be trained and deployed to upscale towards this? Absolutely yes. Early identification possible? Yes. So many check boxes? Ticked yes. Now the question is, are you ready for it? The question to the radiology group is, are you really ready for it? So there's no more thing that, is it an elitist problem? Is it a problem that we in India have to look at? Trivandrum results were startling, and that was a prospective study, prospective community-based study on a representative sample of the whole district on adults. And to come out and say that 49.8% of that particular cohort had some sign of NAFLD on examination is startling. It's a huge number, even though Kerala and Trivandrum have a very high incidence of metabolic syndromes, diabetes, hypertension, and all those things. And considering the high alcohol consumption in Kerala, to come out with this number for non-alcoholic fatty liver disease is startling, to say the least. So I leave you on that note, and you have a feast of talks after this on the clinical aspects, on the imaging aspects. This was just a small eye-opener just to say that this road is not just a mirage. It's not just a dream of the elite, not just a dream of something exotic. It's trying to address a real problem that we must be cognizant of. Thank you so much.
Thank you so much, sir. That was really a very in-depth analysis and a big perspective. And I think it's a big eye-opener to all of us as to how widely prevalent this issue is and how we can, help to address this thing. So again, thank you very much for that lecture. And now I'll call upon Dr. Bhushan Pandit, who is a gastroenterologist, a hepatologist, and endoscopist at Pandit's Clinic, where he's the director, and he's also attached to Jupiter Hospital and LH Hirandani Hospital in Powai, as well as in Thane in Mumbai. So he is again someone who is I've been interacting with him since quite some time, and it's always wonderful to hear him. He is always giving talks at a lot of places, and the reason I thought of him for this program was because he's a believer in the technology, and it really helps us to understand what we as radiologists can do to help the clinicians, and this is what sir will be focusing on over here, and he'll be giving us a good clinical perspective of NAFLD and NASH. So thank you so much, sir, for being here, and over to you.
Yeah, thanks, Rajesh, for those kind words. At the outset, I want to thank Team IRI, the esteemed members, Mindray, and specifically thank you to Dr. Chaubal, because I think when Rajesh came to me with this preventive radiology concept, I was, just taken aback and I was mesmerized. I think this is something which is needed, and as a team, I always feel that gastroenterologists, radiologists, they form a beautiful team. And I think as a team, we can take things a lot further. And as Dr. Rijo said, that I think I am the first clinician on this particular panel, and this is the first program. So I'm very happy to be the Sachin Tendulkar of this particular session as a clinician. I'll be talking, I think Professor Praveen Nermalin has done my job much easier. I think he has given such glaring numbers that the clinical perspective and those glaring numbers are definitely going to make us more interested in prevention of NAFLD. NAFLD is fatty inflammation of the liver. It is not due to alcohol use, basically causing fat built up in the liver tissue. It is part of a metabolic syndrome, and it covers the spectrum of disease activity which happens in patients. It begins as just simple fatty accumulation in the liver called as steatosis, and eventually can lead cryptogenic cirrhosis in certain patients. It's a disease of all genders, ethnicities, age groups. It's more in females. When it happens, the fatty accumulation in the liver progresses to liver inflammation. When inflammation occurs, that condition is called as NASH. So the NAFLD progresses to NASH. Obesity and insulin resistance, as sir has previously said, probably play a strong role in this progress. Still, certain mechanisms of this disease are not clear, though at the end of the, I think, discussion, I'll be clarifying a lot of things. Estimated 20% risk in 20-year follow-up for cirrhosis. Now, this is a very important clinical perspective. What we are going to prevent if we are going to pick up things earlier. Types of NAFLD: non-alcoholic fatty liver, NAFL, simplest form, excessive liver fat, but no complications, very common. I think we see a lot of high resolution machine, excellent radiologists picking up grade 1, grade 2 fatty liver, and a lot of patients even on incidental health check are coming with this kind of a NAFL report with this. And there is a significant amount of lean people. So I would call it as lean NASH, lean NAFL, which are coming up, which is because of excessive fat accumulation. More than 5% of the hepatocytes, if you see histologically, if they have fat, triglycerides in them, that is NFL. NASH is when the inflammation sets in and it impairs the liver's ability to function. It responds in the form of inflammation, inflammatory reaction in the form of enzymes, and eventual complications can set in. And the third type or the stage of NAFLD is cirrhosis, where inflammation leads to scarring, more severe liver complications. So NASH, which is, I think, the intermediate thing, which is very important, the center of the fulcrum of the disease profile. It's a non-alcoholic steatohepatitis, advanced form of NFL. A major cause of liver cirrhosis of unknown cause. So cryptogenic cirrhosis, the commonest cause has been found to be now NASH, especially with diabetes. And so we see a lot of patients with long-term diabetes, elderly patients with all viral marker negative, presenting as first-time variceal bleed. We do endoscopy, we see varices. Retrospectively, when we work up, they turned out to be NASH-related cirrhosis. So that is how it is. It is relatively new entity, first described in Mayo Clinic in 1980s. So I think that is why the whole spectrum in last, say, 4 decades have changed completely. Just to briefly outline 2 types of NASH, primary NASH, basically associated with metabolic syndrome, related conditions such as obesity, type 2 diabetes, and hyperlipidemia, the classic NASH, which we are going to discuss. Secondary NASH is because of obesity-related intestinal surgeries, rapid weight loss in these obese patients, total parenteral nutrition, treatment with drugs such as amiodarone, lipodystrophy, which occurs in these patients, or Wilson's disease, can also be associated with secondary NASH. So interestingly, this is a spectrum of disease. And when we see a spectrum, we have preventive strategy that can be incorporated at every stage of the spectrum. So from a simple steatosis, NFL, to NASH with fibrosis, and eventually leading to cirrhosis. Simply mentioned in this slide, the normal histopathology, which we can see, steatosis, the macrovesicular fat deposition in the hepatocytes. When the inflammatory cells are seen, it is NASH, and last slide shows full-blown cirrhosis or fibrosis. The nodules can be appreciated there. I won't be going into the details of pathogenesis, triglyceride accumulation, insulin resistance. I think Sir has covered a few parts of it. Lipid peroxidation and hepatic lipotoxicity. I think hepatic lipotoxicity is the very important thing. So alcohol will also cause fatty liver. Non-alcoholic fatty liver, the pathway is also a fat deposition. But there is more hepatic lipotoxicity seen in these patients because of cytokine activation and eventual fibrosis in this patient. There is something called as adipocytokines, which play a major role in pathogenesis of NAFLD-related complications, and lipoprotein metabolism is abnormal in these patients. Again, it's a multi-hit game. It's a game. It's a team which we have to treat that. The disease process itself is like, they are coming in together, cytokines, adipokines, oxidative stress, a lot of things. So the first hit is from normal liver to steatosis. The second hit is resulting into inflammation causing NASH, and the third hit, which is fibrosis and eventual cirrhosis. Epidemiology, I think one of the most expert people just before me has given an eye-opener. Briefly, I'll go through that. I'm not going to take much of time. I'm going to rush through this slide. But now this is turning into a pandemic. I think we are now very well versed with word pandemic. So I think we were scared about certain pandemics, but this pandemic is real and it's going to stay and it's going to worsen, believe me. It's a obesity epidemic, which is, involving the population, and the fibrosis in NASH with NASH is seen in almost 40%, more than 40% of significantly obese patients. Sir had given an all India certain states perspective. We had a very interesting Indian study by Sareen et al., where the West had the community prevalence of NAFLD was 5 to 25%. In diabetic patients, when the sonography was done, 30 to 90% of the patients had. With central obesity, around 15 to 20% of the patients had NAFLD. In East, it's around 25%. North, Lucknow and Chandigarh and North Rajasthan area, we have seen that around 32% of the ultrasound reports had
fatty liver as one of the diagnoses mentioned in that. And 32% of urban population is down south. 50% of 4% of diabetics, around 30% of pre-diabetic, and as compared to 22% controls we had found. So controls themselves also had fatty infiltration. So there is more prevalence with more glucose intolerance in these patients. Indians in other countries, there was another study which was conducted in Indians in other countries. We had seen more NFLD than natives actually. So though the mechanisms are different, we are seeing more NFLD in Indian population everywhere. And in last 15 years, 75% increase incidence of diabetes. So eventually, if you see diabetes is going to cause more fatty liver, more NFLD, that is going to exponentially rise. Another important aspect, I'm just going to touch this because this is an ocean, fatty liver in children. We have to be skeptical. We have to be very careful. I think as radiologists now, we'll have to be more focused on liver in children also. 2.6% of the pre-COVID, one of the surveys which was done, 2.6% of pediatric population had that. And obese children, the range was between 20 to 50%, which is, I think, significantly high. Very few, but I think cirrhosis was present in a few patients. There are certain familial diseases. Again, as I told you, I won't be going into details of this. Prevalence of NFLD, normal people without any metabolic risk factors, the prevalence is 16%, mind you. So a lot of these will be lean NASH also. Diabetics, around 40 to 60%. Obese patients undergoing bariatric surgery, 91% of the patients have NFLD, so almost 90%. Hyperlipidemia, definitely 90%. Less than 20 years, we had around 20%, but more than 60 years, we have seen around 40%. And male gender is regarded as a risk factor for progression to NASH and fibrosis. Again, risk factors were covered by Sir. I'll just briefly mention major comorbidities, type 2 diabetes, dyslipidemia, obesity, metabolic syndrome, basically overweight, high blood pressure, high cholesterol, diabetes, all this working together, causing metabolic syndrome. I think this is what is going to cause a major problem. Emerging associations we have found now is, I think, hypothyroidism is very well documented, sleep apnea, hypopituitarism, PCOD. I think PCOS we are reporting off late a lot in young females, and I think we are seeing lean NASH in those females also, basically hormonal changes in these patients, and pancreatic resections are emerging associations which you have seen. Most of the patients are asymptomatic. That is why we have to be careful when the report comes of fatty liver. I think the clinician and even the radiologist now will have to be more attentive. Their antennas should be high up to prevent future complications in these patients. Though they are asymptomatic, 1/3 patient with non-specific symptoms like weakness, fatigue, there will be hepatosplenomegaly and cirrhotic features if there is complications. So symptoms, as I said, mild, asymptomatic most of the times. Occasionally, right upper quadrant pain, we have seen more in children. So a lot of children with vague upper abdominal pain, we have found that fatty liver in this patient, especially in obese children. The signs are obesity is one of the most common features we'll find, high BMIs. As for Indians, we have reduced the BMI values also, high blood pressure, and hepatomegaly in the span form was around 50%. Sign-related chronic liver disease, I think the classic sign of cirrhosis will be found in this patient. Clinical history, I feel we should be excluding alcohol intake. That is one very important. Dietary history plays a major role. Medication history. Exposure to solvent, certain chemicals has been found to be associated with fatty liver disease, and family history of any liver disease. We have a case series now with family history of liver disease, and one of the patients dying of liver cancer because of NASH-related problems, and the family is now, we are under surveillance now. So laboratory abnormalities, aminotransferase activity around 50% of the patients, but may not be there in certain individuals. SGPT, ALT usually greater than AST by hallmark. So when the patients come with me with a fatty report, they tell me there is a problem with the liver. So I tell them SGPT is higher. They say, yes, sir, are you a Jyotish? It's a very well scientifically noted point that ALT will be higher than AST. If AST starts increasing, if SGOT starts increasing, that is where the cirrhosis or the fibrosis starts setting in. Glucose intolerance around 30 to 50%. Hypertriglyceridemia is very common in these patients. And then again, other causes of liver diseases we have to rule out in these laboratory abnormalities. Alcoholism, autoimmune liver disease, Wilson's disease. viral hepatitis, I'm sorry, and hemochromatosis are the diseases which we have to. There are certain diseases which can cause hepatic steatosis. So excessive alcohol consumption, as we said in history, and patient GGT, other markers can be done. Malnutrition, medications, parental nutrition. Hepatitis C, acute hepatitis D are very well associated with steatosis, so we have to be watchful for that. Wilson's disease, as I previously mentioned. Coming back to the main topic here, classical tools for diagnosis of NAFLD, liver enzymes, as I said, SGPT more than SGOT, GGT. Not reliable for diagnosis, sensitivity in the range of 60%. But again, always done as a baseline. Ultrasound, definitely extremely important. I think now this has become, it's like I always call it as a stethoscope. What is a stethoscope to a cardiologist? I think for a gastroenterologist, ultrasound, a radiologist friend is like that. Inexpensive, accessible, but sometimes cannot distinguish between fibrosis. We'll come to that later, part of my talk. CT without contrast, yes, definitely. Better in obese patients, and but it can be affected by iron and fibrosis, and less accurate with lesser steatosis, which is there. MRI and MRIs definitely detects mild steatosis also. Quantification of hepatic fat, which we need as clinician. And as a therapeutic goal, we see reversal of that fat from the hepatocytes. If that is happening, I think that is what we need. Liver biopsy, gold standard, but again, invasive and complication. Again, in a radiologist allied group, I don't want to put this, but this is a very interesting slide. Grade 0, grade 1, grade 2, grade 3. In an ultrasound, in a CT scan, unenhanced, and actual MRI, going from grade 0 to 3. I think so. This is how we are going to quantify, we're going to grade, and even a good sonologist can give us a lot of information. Liver biopsy, I think overrated in all studies, though considered as gold standard, but I think it's the imperfect gold standard, as I call it. It is used for confirming diagnosis and for prognostic information in fibrosis patients. But there are definitely limitations. I, as a clinician, I personally don't prefer doing liver biopsies now. Non-invasive, imaging-based, clinical-based, the more information we get, I think that is going to be more useful. Liver biopsy will be for only select group of patients. Limitations, as we all know, invasive, painful. If I am the patient, I won't want a liver biopsy. I would need a sonography from Dr. Chaubal or some great person like him, and I would be happy with that rather than undergoing a liver biopsy unless there is some definitive indication. Again, just independent predictors of fibrosis. So if these patients are there, we have to be careful. Diabetes, initial low fibrosis in these patients on scans, if you find high body mass index and elevated liver enzymes. So if there is a liver response in the form of enzymes, the fibrosis is going to go more because the liver is going to respond in the form of fibrosis to that inflammation. Again, a very busy slide, age more than 40 to 50. These are predictors, again, more severe histology. Interestingly, as I said, AST increasing, so SGOT increasing more than SGPT. If the ratio is more than 1, then there is more chances of higher fibrosis. Higher immunoglobulin A as a marker we have found. So basically, is a liver biopsy necessary? Yes, if only in select patients where there is doubt in certain diagnosis or we have to rule out certain other diseases. Again, a very busy slide. Basically, natural course, NAFLD around 70 to 75% will be isolated fatty liver. This is, in fact, there is nothing much happening in this patient. Mild inflammation will be there, but nothing significant progression. 20 to 25% will develop NASH. Now, very important, 11% over next 15 years out of this NASH will develop NASH-related cirrhosis. And out of this cirrhosis, I think this is a very important slide. Out of this cirrhosis patients, NASH cirrhosis, 7.2, so 7% over next 7 years will develop HCC. So preventive radiology, I think, see how relevant this interaction is going to be, because we at every stage, if we intervene, if we pick up early, we do measures to prevent further progression, we are going to create reversal of this flow charts, and we can reduce a lot of decompensations and HCC and eventual, I think, liver transplant, which is now, this is commonest cause of liver transplant in Western world today. There is increased rate of death. I'm coming to that as compared to the general population. I think this is very important. Dyslipidemia is very common in this patient. This important slide I just want to mention here because when we are doing preventive liver-related thing, when we prevent liver injuries, liver problems are going to be reversed by prevention. Coronary vessel disease is very closely associated with NASH because of the abdominal obesity, and we have found that chronic inflammation, high CRP, high IL-6, hypercoagulability in these two patients, which can cause a lot of cardiac events in patients with NASH. So this is somewhere if we pick up early. So when a patient comes to me with fatty liver, they ask me what is the significance. I tell them that if the fat has started, triglycerides have started depositing in your liver, there is a chance that they are going to get deposited in your coronaries. So let's start working together. Let's start lifestyle modification. Let's reverse this progress of liver disease as well as coronary disease. So the prevention will come here in a big way. Mortality, again, I won't be going through this busy time. The main line is the mortality rate is higher, as I showed here, definitely higher than general population in patients with NAFLD, NASH and advanced fibrosis. If there is F4 fibrosis, the survival significantly reduces. Now, I think this is a very important thing. And one line which I want to mention here that HCV cirrhosis we have very well understood. Now, NASH-associated cirrhosis, we have found that similar prognosis as like HCV cirrhosis. So that is a very important thing. If fibrosis and cirrhosis sets in, then there's going to be a very significant high mortality. Again, a busy slide, but just to tell you that at various steps we can prevent disease formation from steatohepatitis to cirrhosis. If we produce preventive measures at these particular stages, we can. So how do we evaluate? How can we do this preventive evaluation? The fibrosis can be evaluated by clinical examination, blood markers, Fibroscan, imaging definitely in this allied group. That is the most important thing. Hepatic histology only when required. And there is a biological workup. I'll be touching that at the end. Non-invasive, so NIT in the short form are very easily available now. They're safe and simple. Multiple NITs can be very predictive, and we can identify patients with either early stages of fibrosis also, and it's very cost effective, especially as compared to biopsy. What is an ideal non-invasive test? I think what we need to develop as a preventive, I think what Mindray presentation also showed that the newer machines are going to pick up things much better and clearer, and even the areas of the liver can be well documented. So simple, reproducible, readily available, less expensive than biopsy, less expensive than undue over charging tests, predicts full spectrum of fibrosis, reflects changes during therapy. I think this is very important. Again, as a clinician and radiologist team, we need to, when the patient comes for a follow-up radiological evaluation, we should be able to see and document changes occurring with therapy. So commonly used non-invasive are the simple ones called NAFLD fibrosis score or FIB4, which we are commonly using as clinicians. FibroSure, FibroSpec, more like study-based, and imaging we all know. Again, NAFLD fibrosis score uses certain parameters like age, AST, ALT, platelet count, BMI, albumin, and FIB4 score. And then there are various cutoff values. I'll be sharing the slides with you all eventually. So I won't be going through the details because it will take a lot of time because we are running short of time already, I guess. So NAFLD fibrosis score, it's a very complex thing, but it is used to classify advanced liver fibrosis into two categories, and it's an independent predictor of advanced bridging fibrosis or cirrhosis in patients, where higher scores will definitely be, merging with fibrosis scores. And NAFLD fibrosis score predicts long-term outcomes with NAFLD, so the prognostication can also be done. There are available calculators like in FIB4 score, where it's based on AST, ALT, and platelet count. The formula is given here, and we have a simple. So this is an app available. It predicts advanced fibrosis with high specificity, reasonable correlation, with head-to-head with MRI and liver biopsy we have found, and it, in longitudinal changes can be predicted in this patient. Now, again, coming to preventive aspect of the whole discussion, all my radiologist friends, I think we saw the machines, evolving so well. Software is being available. Now, this is a simple calculation which even a radiologist at his center can put these values in, calculate the score, and along with the sonography findings, along with the elastography reports, along with the fibrosis scores, if you get these scores in the form of biochemical parameters, I think this is how the team is going to evolve, and a lot of preventive work can be done together. Again, we can definitely predict stage 2 versus stage 3 to 4. Definitely higher fibrosis is better predicted. The problem is this intermediate, indeterminate kind of a group. This is where good sonography machines, good elastography machines are going to come in picture, where even just by imaging, if we can pick these patients up, along with our scoring system, we can correlate that better. Liver stiffness, I think everybody in this August group knows it is assessed by ultrasound and more recently by MRI. It evaluates the velocity of propagation of a shock wave in the liver. The rationale is that normal liver is viscous, so not favorable for wave propagation. Fibrosis increases the hardness, so there is rapid propagation. This is the Fibroscan device, which is an electronic platform which is integrated with the computer, and then we do stiffness measurements, and then we analyze the database, and certain scores come. There is a transducer, and then there is a vibrator which recognizes. We all know how it is done. The explored volume is around depth is 4 centimeter only, and around 1 centimeter of the range of the thickness is cylinder is seen. But the volume is bigger than the liver biopsy. That's the only positive find we see here. So we take around 10 shots. Success rate is more than 60%. Cannot be used in acute hepatitis, acute exacerbation of liver diseases, ascites or cholestasis, or if there is any vascular condition. And there is a very funny aspect that there are different cutoffs for various different chronic liver diseases. For HCV, it is different. For NASH, it is different. So it's a very, it can be very tricky when we see a fibrosis score, sometimes in Fibroscan. These are the basic principles. I won't be going through the details, but we all know that we get a kilopascal score, F0, F2, F4. This is the range which we get and can be compared with Metavir score. So from F0, which is normal, so less than 6 score, we rule out any definite hepatic fibrosis. So this is more reliable here, that we can rule out fibrosis if the score is less. And as the score increases, more than 12 will be more like, 8 to 12 is bridging fibrosis and then cirrhosis. Liver stiffness, again, F0 to F4, more into going into cirrhosis. Now, Fibroscan, the advantage initially was said that anybody can do it. But if you ask me, I am not a person who believes anybody should do anything. Fibroscan, the disadvantage is that it is completely operator dependent. Anyone can do, and I think there is absolute misuse happening. I'll just take 1 minute here additionally, that a lot of my colleagues are doing Fibroscans. Certain companies provide that, and I am seeing irritable bowel syndrome patient and some other acid peptic patients also having Fibroscan reports attached to that. I think this is where the importance of an investigation, the niche of an investigation goes down. So it is, I think this is what we as clinicians need to understand, that radiologists are much better. They have a better imaging acumen, and I think leave certain things in their domain, and as a team we can work better. I think we all know the disadvantages. There is no anatomical image, limited depth, unpredictable, and almost 3 to 20% of the time we cannot get the results itself. Again, a lot of pitfalls in this. The advantages of shear wave over transient elastography is that we get an anatomical guidance. I think so when elastography report elaborate comes from, say, Dr. Chobal or somebody, we have images, we have score, we have a basic ultrasound evaluation also, we have a portal vein size also. So there is a anatomical guidance of those fibrosis areas, those fatty areas, not influenced by body mass index or ascites. The usual reproducibility of the report is going to be the same. Staging of fibrosis can be done much better. Evaluation of deeper tissues can be done much better. There is lesser technical failure, higher accuracy. And there is adequate evidence and updates which are happening, as we said even in the presentation of Mindray. I think it is going to be more evolved. So even as gastroenterologist, I would rather, go for elastography and other investigations with my radiologist friends, rather than, just blindly putting a probe somewhere and getting some readings and getting satisfied or doing some wrong kind of a judgment. I won't be talking about this because I think two esteemed speakers are going to talk about ultrasound. And so I won't be, this is just an advantage which I wanted to say. Again, Srinivas sir is going to present about this. His assistant is going to speak on this, MRE. But this was the slide which I wanted to share because I think the clarity with which the MRE stiffness can guide us about fibrosis, I think this is exemplary. And this is what good imaging can do to clinical practice and modify the outcomes in patients. I think this is very important. Again, a very busy slide, but very important slide. I don't believe in liver biopsy as a primary or, even this is the last test for me. So when I always make a presentation without a liver biopsy as an option, NFLD, if the low scores on FIB4, definitely we observe this patient and we consider serial FIB4 measurements. We do basic ultrasounds and elastographies in these patients. If it is increasing, then we gradually go towards cirrhotic stage. The scores are evaluated and accordingly treatment protocols and medications can be done to this patient. Again, just to, this is a poster slide, as I always call it, non-invasive biomarkers. As sir was saying that there are huge number of biomarkers which are coming, which are imaging biomarkers, which we all know, genetic scores, there is, fibrosis score, there is inflammation scores, which are going to be there. And eventually, I think these biomarkers, which are non-invasive, along with radiology, are going to change the game of NFLD and NASH. And believe me, that is the future of hepatology practice. Again, certain omics, which I think Dr. Reji had said, and the previous speaker also tried to mention, but this is, again, just to show that there are a lot of things, there are huge things happening in NASH, NFLD, and NASH-related cirrhosis, where we can have these wet biomarkers, genomics, proteomics, and metabolomics, which can guide us in decision-making these patients with radiological friends. Just to summarize, it's, I think, epidemic proportions in India, of diabetes and obesity, and the complications of NFLD are becoming a major public health issue. Mostly patients are asymptomatic and benign, but NASH may lead to cirrhosis and HCC. In this spectrum full disease, as I call it as a spectrum full, it's a very spectrum full disease. Prevention at each stage, from say simple steatosis, mild fibrosis, severe fibrosis to cirrhosis. As a team, gastroenterologists, hepatologists, radiologists, if we work together, I think that we can work on all fronts and we can reverse a lot of things. I think vigorous public campaign, I think this initiative of IRIA and certain companies which are there, I think this is the future, how we should go. As a gastroenterologist, I think we will be very much happy to be part of all such ventures. Vigorous public campaign and education to reverse this, and eventually NASH can be reversed. Obesity, diabetes can be controlled. And preventive radiology, my friends, is going to play a significant role in management of this NFL disease. Now the famous word pandemic, I would say. Thank you. Thank you for patient hearing. I think we'll be taking questions at the end of the
Yes. Thank you so much, sir. Absolutely fluid presentation, and I'm sure all of us will have a lot of questions for you, and we're going to bombard you with a ton of them at the end. So hope to get onto that. So then we'll move on to the next talk meanwhile, and I'll invite Dr. Ritu Kashikar. So Dr. Srinivas Desai sir was supposed to be here. Unfortunately, he couldn't make it, but he's sent us a very kind message which we shall run before the lecture. And Dr. Ritu has been a consultant in Jaslok since 2013. She does a huge amount of MRs and CTs, and we've been doing some studies in Jaslok with MR elastography and fatty infiltrations as well. She's published a number of articles and written chapters and books as well. And she's a proud recipient of the prestigious Dr. Ashok Mukherjee Award in IRIA in 2020. So with that, over to you, Dr. Ritu. And before that, I would just request somebody to play Dr. Desai's video.
Will do, doctor.
Technical
sure. Yes, we are doing, sir. We are doing.
Doctor needs to stop sharing the screen.
Okay, I think
Dr. Can you please stop sharing the screen?
Okay, sorry.
Dr. Srinivas Desai is the chairman of the Research and Education Wing of Indian Radiological and Imaging Association. The preventive radiology research, multi-centered research, there are 3 committees involved: the ethics committee of IRIA and the scientific committee, and also the research education wing. The 3 committees has to decide on the grants awarded to the centers that are part of the multi-centric studies. And Dr. Srinivas Desai is the chairman of the research education wing of IRIA. And as he had a emergency travel plan, sir could not join us. And this is a message from Dr. Srinivas Desai, sir.
Good evening, everybody. I congratulate IRIA for conducting these symposia and seminars of preventive radiology. I particularly congratulate Dr. Rijo Matthew for having undertaken and spearheading this movement of collection of the data of fatty liver and NAFLD and NASH in India. I also congratulate Dr. Pushpraj Behtale and Dr. Amarnath for supporting this movement. I wish all the best for today's symposium. As we all know, MR plays a big role in assessment of the liver in NAFLD and NASH. I'm sorry I could not participate in today's symposium as I'm out of India and have been traveling. But you have a better alternative, a very able Dr. Ritu Kashikar replacing me, and she will deal in detail about the applications of MRI in evaluation of fatty liver in NAFLD and NASH. Wishing the symposium all the best again. Thank you.
Over to you, Ritu.
Thank you, sir. A very good evening to everyone, and thank you for having me on this platform. I hope my slides are visible.
Not yet. You have to share the screen.
Not yet, doctor.
Just a second.
Yeah.
Are they visible now?
Yeah.
Please.
All right. So a very good evening.
Slideshow mode, please.
Yeah. Sorry. Yes. So a very good evening to all of you, and thank you for having me here. Now, I'm going to largely focus on the MRI techniques of fatty liver assessment and liver fibrosis. Now, as has been very eloquently spoken by both Dr. Bhushan and Dr. Praveen, NAFLD is like the current pandemic. Now, fatty liver, whether because of non-alcoholic reasons or because of alcohol, is something that is going to take a downhill course and perhaps lead to very ominous complications unless prevented at an early stage. And this is a fact that has been emphasized again and again in the previous lectures. Now, this brings me to the outline of my lecture. Now, in the beginning of my lecture, I would need to just sort of talk again for the need of non-invasive liver fat estimation, which has been spoken by Dr. Bhushan again and again, how against he is of liver biopsies. Having convinced you with that, I would like to talk about why MRI and then discuss the various imaging techniques as far as MRI is concerned in the assessment of fatty liver and touch base a little bit on fibrosis. Now, I'll try to keep this talk as less technical as possible so that I can interest the entire audience and to give you all an overall summary as to what exactly MRI can do. Now, obviously, biopsy has been considered as the gold standard, but like Dr. Bhushan also said, that it does come with several advantages. Firstly, it is invasive. Second of all, it can be expensive, sampling error, and a definite risk of complications does exist despite whoever does the biopsy. Having said that, patients with fatty liver disease may have to be subjected to repeat sort of evaluation after being on a certain diet or after having sort of taken care of probably the alcohol factor. So it's not something that a patient would like to undergo again and again. Hence, the need to have a certain non-invasive sort of imaging. Now, ultrasound has traditionally been the method, and it is still one of the most important methods of fatty assessment. It is on the basis of the ecogenicity of the liver. It talks about the grades of fat, and this will be discussed in details in the lectures to come. But the perils or the demerits of ultrasound would be yes, it is observer dependent. It is equipment dependent. There are certain confounding factors, particularly when you're looking at the population of non-alcoholic fatty liver disease, wherein obesity is something that does tend to play some sort of a role, and it may interfere with the interpretation of assess or the grading of fatty liver. And there can be other confounding factors such as presence of fibrosis and inflammation, which can also alter interpretation. Now, what about CT scan? Now, as far as CT scan is concerned, CT is still used in, let's say, a donor fat evaluation, in which we do calculate the hepatic attenuation index. That is, we take the density of liver at 10 places, compare it with that of the spleen by subtracting the density, and CT is still used quite a bit in fatty assessment. But is it really used in patients with NAFLD to monitor these patients? Not really. The reasons being that CTA, there is exposure to radiation. Second of all, if there is mild steatosis, CT is not able to detect it. Hence, it is not very suitable for the, for the probable patients who have fatty liver disease. Presence of confounding factors again, such as if a patient has hemochromatosis, if he has a high iron load, which tend to increase the density of the liver. Because when fat is present in the liver, instead of looking like this, tends to slightly look a tad bit darker. So this is the basis of, identifying fatty liver on CT, and we can actually quantitate the value by drawing ROIs on the liver. But if there are confounding factors such as iron or patients with glycogen storage disease, the results are definitely going to be misinterpreted, because one disease is increasing the density of the liver and the other is decreasing. So the value that we'll get is something in between, and hence is inaccurate. Low CT values, you can also see in patients suffering from hepatitis who have edema and inflammation of the liver for various reasons. And most of the times when we are calculating the attenuation of the liver, we tend to compare it with the spleen. And the spleen per se is an imperfect comparative or a standard reference, because it can also be affected by various disease processes, albeit in a smaller population. Which brings us to the next topic of discussion in my lecture is, why should we choose MRI? Now, if I were to simplify it and put 5 or 6 points ahead, is A, it is non-invasive. It can be easily performed in obese population. The results will not change regardless of whether the patient is 50 kgs or 120 kgs. The entire liver can be sampled. We are not just looking at a part of the liver, but we're looking at the entire liver. Confounding factors such as iron don't interfere with the results. It is quantifiable. So you'll actually not just get whether there's presence of fat or not, you will actually get a certain value of fat, and which can be compared with or which can be kept in mind or borne in mind, and the patient can be monitored on the basis of that, following diet or stopping alcohol. And I will come to initially the last part of my lecture and say why it is the one-stop shop for imaging of most of the diffuse abnormalities or diffuse liver diseases. So what is basically, what are the methods of estimation of hepatic fat on MRI? Now, traditionally, when liver fat imaging started, we started off with a relatively simpler procedure, which is called as chemical shift imaging. Now, as far as evaluation or calculation of hepatic fat is concerned, the basis of the entire MR calculation is the chemical structure of water versus fat molecule. Now, I will not get too much into the physics or the chemistry, but what we just need to understand is that water, being composed of 1 oxygen and 2 hydrogen molecules, and this is a fat molecule which is composed of a chain of carbons and some hydrogens attached to it. Now, because the oxygen molecule tends to, in a magnetic field, the oxygen molecule tends to attract all the electron towards it. So the entire electron crowd is attracted towards that 1 oxygen. So in the magnetic field, the water or the hydrogen molecules in the water are free to precess. And by precess, I mean they're free to move around. And so they move slightly faster. Whereas in a fat molecule, both the carbon tends not to be as selfish as the oxygen, and the electron cloud is sort of distributed all over the molecule. So the molecules of hydrogen, they precess slightly at a slightly lesser rate, just a teeny weeny bit slower as compared to what they do in water. And this is the entire basis of MRI in fat estimation, just the chemical difference between the water molecule and the fat molecule. And this is what we exploit, and we are just getting better and better at, being able to identify the difference between these two. So what we do get by using in this MR quantification of fat is two separate peaks, one of water and one of fat. And both of them are separated by the smallest amount, but it is enough for MRI to be able to detect it. So the simplest form of MR fat quantification is something that is called as in an opposed phase imaging. And this is what is available on most scanners, in which we sort of calculate two sets of imaging, one in phase and one opposite phase. And then we use a sort of a simple equation to be able to quantify the percentage of liver fat. Now, this particular in-phase and opposed-phase imaging, if you are to look at patients, two separate patients with a fatty liver disease, we can see that this is the in-phase disease. This is the liver. Now, there is a drop in the signal. You can see that the liver in the opposed phase looks darker. And this is what fat does. The liver will look brighter on the in-phase, and there will be a signal drop in the liver in the opposed phase imaging using this particular MRI technique. Now, as opposed to if you look at the images below, this is a boy with more severe liver disease. He had a history of familial triglyceridemia, and he's only 20-year-old. But if you look at the liver and you look at the liver on the in phase, it looks bright. But if you see that there is a dramatic drop in signal, so even just by a visual inspection, you know that this is a more severe form of disease. Having said that, we do not stop at a visual inspection. We actually go around and take the ROIs and calculate the percentage of liver fat. Having said that, as far as this particular method, and it is perhaps the oldest method of hepatic fat estimation using MRI, it does come with certain disadvantages, some being confounding factors such as iron. So the iron, which played a negative role as far as CT or perhaps even ultrasound is concerned, continues to be a threat if this particular sequence is used even in today's day and age. And hence, this particular method is not absolutely foolproof for liver fat estimation. There are certain other technicalities that are associated with this method that can perhaps bias results or not lead to absolute accuracy of results. The advantage of this method being that it is available on all scanners and it is free. So you don't need to particularly go ahead and buy a software to measure it, but it is definitely available on all scanners, and it is even sensitive to mild fat, which CT is not capable of doing. So what has eventually happened is that the same principle that I have mentioned of water being separate and the chemical composition of the fat molecule being separate is further and further more exploited, and the imaging advances just continue to get more and more refined in order to be able to pick up that difference between, or the difference of movement or the precision between these two molecules. The current day imaging that is used in most good to high grade scanners is what is called as proton density fat fraction, PDFF, or multi-Dixon are the other terminologies that are commonly used. And if I were to just summarize the physics, is that in the earlier imaging, only magnitude information was used. But in this particular imaging, both magnitude and phase information from three or more image sets is acquired for more accurate separation of fat and water signals. So basically, we aim to do the same thing. We just aim to do it a little better. And we aim to sort of stop the confounding factors from bothering us. So the lesser the confounding factors bother us, the more accurate will be the fat estimation, and the more closer will be the interpreted results compared to histopathology. So again, there are simple equations to sort of compute into after measuring the ROIs. Having said that, in the present modern day scanners, we do not actually need to do the math. As soon as we put the ROI on the image, the values will automatically emerge. So for those of us like me who are a little bit mathematically challenged, it is Not perhaps so scary to look at formula, because we don't really need to do that. This is just for understanding, and in certain systems, the direct measurements may not be available. Having said that, whoever does it, it is very, very easy, and it just involves drawing ROI and basically doing simple mathematics. So this is currently what is used in most centers, and this is called as proton density fat fraction. These are the in and post phase images. We see that there's a signal drop. The PDFF images would look something like this, and I have automatically directly measured. You can see 12%, 10%. So obviously there's going to be a variability. We calculate the average. In fact, the system will calculate the average, and we can get the percentage fat in the liver. This is again another patient where these are the in and post phase images. We see a more severe drop. It's on eyeballing itself, we see a more severe drop. On the PDFF, we see that there is a fat percentage of 25%, moderate fatty changes. So again, this is quite, the values are very precise and very accurate. So this is presently the best available and most widely available methodology of fat calculation. And the importance is that it does not, like the previous MR imaging, or when MR imaging evolved, like the first thing I showed, the chemical shift imaging, this particular proton density fat fraction is not influenced, or at least in the present day, by the other confounding factors, by iron, which I measured. It is simple and it is reproducible. Anyone can do it. If I do it tomorrow and day after my colleague does it, the results will not change. So it is not observer dependent, and it has shown excellent correlation with histopathology and MR spectroscopy, to which I'll come in a little bit. It is an excellent method to use when sort of a patient is on a diet, weight loss, alcohol abstinence, to monitor for the serial drop in liver fat. It's MRI, so there is no radiation involved. It is absolutely non-invasive, and hence, and it is very, very accurate, and it correlates extremely well with the histopathology. What's important is that a proton density fat fraction will not change. The values do not significantly or significantly change with a change in either system or the strength of the magnet. So I can get a scan performed at a certain place, and if the person cannot come back to the certain place, a scan performed maybe a little bit later will still be valid at a different system, perhaps on a different field strength. So the values do not change dramatically. So that significantly improves the reproducibility of this particular method of fat estimation. Also, having said that, proton density maps show an excellent correlation with MR spectroscopy, and MR spectroscopy is now considered the current gold standard for hepatic fat estimation. And I'll just come to what MR spectroscopy is in a little bit. So as far as liver fat imaging is concerned, and today's day and age is concerned, proton density fat fraction, or what is also popularly called as multi-Dixon technology, is currently the in-use technique, and provides excellent correlation with both histopathology, with both MR spectroscopy, as to the estimation of liver fat, is reproducible, and it can be, and results do not vary with systems. So a GE or a Siemens, the results will not be very different. So very high sensitivities have been reported. There are, of course, different sensitivities across different papers, but this is one of reporting very, very high sensitivity. Bringing us to the next and one of the most accurate of the current gold standard of fatty liver estimation, albeit it is still not widely available, is what we call MR spectroscopy. So now what we saw in the earlier two is the same thing. It's a fat molecule, it's a water molecule, and we want to exploit the differences. There we do it a little bit indirectly. Here we actually see the peaks of the fat and the water, and we measure the fat. So this is the most non-invasive, but it is the best, most direct method of estimation of the hepatic triglyceride content. And having said that, if I were to not put it in very, very simple words, if the fat in the liver is mild, there'll be a small peak. If it's moderate, it will be a slightly bigger peak. If it's severe, it will be a slightly bigger peak. We need to sort of actually measure the values. It has to be computed in a small little flowchart, and we get the results. Now, I'm lucky to be working in an institute where we can actually perform MR spectroscopy. And this is a patient who had a mild fatty liver, but you can see that there is a small lipid peak. So this is what it looks like. So spectroscopy is essentially a sort of a chemical, is an analysis of the chemical composition of something. So water is present in most things. It's present in the liver. So needless to say, there'll be a H2O peak, but lipid, called as lipid over here, there's a small peak over here. This patient had mild fatty liver. So the advantages of MR spectroscopy is, like I said previously, it is absolute concentration of fat. It is not using or calculating it indirectly. It is the absolute concentration of fat in the liver. It will even detect the smallest amount of triglycerides in the liver. It is accurate, and it can be used in monitoring therapy. And again, it is not affected by the presence of fibrosis, iron, and glycogen, because we are actually looking at a lipid peak. We are not looking at the other constituents. The disadvantages is, yes, this particular technique is not readily available in a lot of, in most systems, or most scanners do not have it as of today. Till a couple of years ago, scanners did not even have proton density fat fraction. So we do not know what is to come. But as of today, yes, it is not readily available. Hence, it is by and large used for experimental or for research purposes. But we do not know what is to come in the days. Yes, initially there is an issue about sampling a certain small volume of liver, but so we need to do it at multiple sections. But having said that, I think soon in the days to come, probably these factors will be overcome. Which brings us to the last part of my lecture, which is MR elastography. As has been spoken by Bhushan sir, it is elastography is a technique used to measure the stiffness of the liver, the shear wave. Like he said, that the liver is hard and the beam will penetrate through the liver faster. So you get a higher value, which is measured in terms of kilopascals. And this is what the equipment looks like. And these are the kind of images that we get, and we post-process them to get these sort of pretty purple blue images, which sort of, with the presence of cirrhosis and with the presence of fibrosis, turn to give a more reddish hue. These colors are fairly standard for most scan systems. And so this is just to show a couple of examples of a relatively normal volunteer with a stiffness of 2.45 kilopascals. There is a sort of a grade and a stage that can be provided for this. Less than 2.5 kilopascals is normal, 2.5 to 2.9 is normal on inflammation, 2.9 to 3.5 is F1 to F2 fibrosis, 3.5 to 4 is 2 to 3 fibrosis, and 4 to 5 is stage 3 to 4 fibrosis, and more than 5 is what we get in patients with cirrhosis, like is shown in this example. The liver sort of becomes more red on the color scale, and the stiffness increases. Again, it's something that is very easy. Even having said that, a technician can do it. It is very, very reproducible. I can do it tomorrow. The values will not change. So it's just a really easy, it's just really easy to do. It takes a really short acquisition. Times are all less than a minute. So the patient does not really need some, phenomenal breath hold or like be in a claustrophobic MRI for the longest time. Having said that, even, if a patient is claustrophobic and we are to calculate the proton density fat fraction, it is also a very, very short sequence in most present day scanners. So it's not really torture for the patient as well, that they don't have to be in the scanner for the longest time. So again, elastography correlates very, very well with the fibrosis in the liver, and this has been reproduced in various papers. So as far as MR elastography is concerned, the advantages would be that a larger sample or the entire liver is covered. So there is minimal inter-observer variability. That means I can do it, my resident can do it, a technician can do it. The results really don't change. The fact is that we can perform it in conjunction with fat or iron estimation. And so we can get a very comprehensive report as to what exactly is happening in the liver. The main limitation is that sometimes the results can be confounded by the presence of high iron overload. And so that remains a limitation, but again, with the more sophisticated technologies, that is being overcome. On our system, which I'm currently working on, there is something which we call as T1 mapping, which is it's used a lot in cardiac imaging, but now it's sort of been, coming a little bit, or we're trying to use it a little bit in liver imaging. Again, it's a method to quantify hepatic fibrosis. So I don't know yet. We've done a study over here, but the results are good, but we need larger data. So I don't know whether T1 mapping can be the future to detect liver fat, liver fibrosis, but that's something that we need to keep an eye out on. And just before I end my talk, I would just like to show or emphasize on the beauty of MRI with just this one particular patient. This was a 25-year-old boy. We've been following up for years. He is a patient of thalassemia major, obviously history of repeated blood transfusion. He came for, estimation of the hepatic iron as well as fibrosis. Now, this is the liver. As we can see, the liver looks very dark compared to the paraspinal muscle, which is an indirect indication that there is a presence of iron in the liver. This is an elastography, which we can show that the liver stiffness is 2.87, which would fall anywhere between normal to sort of inflammatory. The liver was not cirrhotic, but in the same sequence, we could calculate both the liver fat as well as the iron content of the liver without without any complex sort of equations. So this just goes to show that MRI can be the one-stop shop for evaluation of all liver diseases, diffuse liver diseases, whether it's fibrosis, whether it's fat, or whether it's iron. Which brings me to my take-home message is, like I just mentioned, it is the one-stop shop. The advances in the more sophisticated machineries have overcome these complex confounding factors. Iron does not bother us so much. Obesity does not bother us any which ways. And the other sort of more, machine-related confounding factors have also been overcome in most systems. And I'm not even talking about a 3 Tesla. I'm even talking about a 1.5 Tesla magnet. The results are reproducible with very little variability. I can do it, someone else can do it. It's radiation free, so there's no harm in subjecting a patient repeatedly to MRI. And obviously, at the end of the day, it is non-invasive, so it has obviated the need for a biopsy. Thank you.
Thank you, Dr. Ritu Kashikar, for that elaborate lecture on MR. Now, as clinical radiologists, I feel we have to approach this problem of NAFLD and NASH with a multimodality approach rather than being a MR specific, though MR elastography has got lots and lots of advantages in terms of a comprehensivity that can give a lot of information on the fat estimation, the fibrosis estimation, and also on the other collateral information that can be given by MR. And of course, MR has got certain real good advantages with the kind of patient habitus too. But what is essential in a clinical radiology perspective is to have, because we have got a large numbers that needs to be screened. So multiple modalities has to be used. The clinical parameters has to be utilized. We need to have a scoring system. Your clinician is more worried about the NASH cases having the fibrosis. What is a quantification of fibrosis that this patient has? So what are the modalities? Imaging offers an opportunity to objectively look into this. That is even from from Fibroscan, which is a vibration controlled transient elastography, to a point shear wave ultrasound elastography, to a 2D shear wave elastography, to MR elastography. We have got a whole array of imaging modalities that can give a qualitative and quantitative information on fat, not only on fat assessment, but more importantly on the quantification of fibrosis. So we have to see this in a larger perspective, the clinical radiologist perspective, with a large community being screened in a preventive radiology program. So the modalities that has to be used in an algorithmic approach has to be brought in here. So to give that perspective, I have Dr. Nitin Chaubal, sir, to talk on a modality that has got a wider availability and wider acceptance and easy to use, that is an ultrasound, which can not only provide an assessment of fat. Now, the real problem is not a fat assessment. It is a fibrosis assessment that is going to be making a significant difference in the management. So to give that perspective on fat assessment and the fibrosis assessment with ultrasound, I invite Dr. Nitin Chaubal, sir, who is my teacher at JSLOC. 25 years back when I was a registrar in JSLOC, but he was one of my role models, and I still respect him a lot. Thank you, Nitin Chaubal, sir, for joining this symposium today. May I invite you to give the lecture today. So ultrasound elastography and fat assessment, where do we stand? Yes, sir, it's visible.
Yeah, thank you. You can see the screen, right?
Yeah. Yes, sir.
Okay, great. Thanks, Rigo, for this initiative. I think we already said that IRIA is now doing a wonderful job in this preventive radiology. And of course, today our focus is on non-alcoholic fatty liver disease. So what I'll be doing is touching upon the role of ultrasound in estimating fat, in estimating fibrosis. And we'll also touch on how ultrasound is coming into being for also picking up inflammation. So there are three things which we'll touch upon. So we already said that it is a large spectrum of disease, which ranges from simple steatosis to non-alcoholic steatohepatitis to fibrosis of various stages to cirrhosis. What we don't want to see is, of course, the complications coming out of this, like chronic liver disease, the liver failure, and ultimately, which could potentially give to lead up to liver transplant and even mortality. What we want to do is to pick up things at an early stage. And as Bhushan said, that it is not a disease which just comes like that, like a stroke. It gives you time, it gives you years. What we need to do as a team is to pick up things at an early stage, pick up early, first of all, fatty liver, pick up early inflammation, pick up early fibrosis at a stage where it is reversible, and then rather than pick up things when it goes to a stage of cirrhosis or late fibrosis. And we will see the role of ultrasound today. So Bhushan has pointed out the limitation of liver biopsy, and just out of my experience, like I would say that I have been in JSLOC for now more than I think 35 years or so. And in the earlier stages, every week, we used to do at least 3 or 4 liver biopsies. But of late, liver biopsies are a rarity. I mean, it's once in a while thing which we do. So the reasons are, of course, quite obvious. There's a lot of inter-observer variability in reporting. Even in a place like Mumbai, there are hardly 1 or 2 good pathologists who are able to report liver biopsies well. So that's the problem. Then, of course, it's a technique which is invasive with its own problems like pain, bleeding, and occasionally even mortality, which can come up as well. So with this, of course, the role of ultrasound, I would say, is in 3 sort of ways. One is, of course, in a diffuse liver disease, is to pick up fatty liver. We will see how it is coming up as far as inflammation is concerned. And it is very well established as far as fibrosis is concerned. There is no doubt about it at all. So, okay. So first of all, we'll talk about fatty liver. And Bhushan has already talked about non-imaging biochemical markers, which I'm not going to touch upon. But we know that there are some scoring systems and all these have limitations. The most important thing is that conventional ultrasound, whatever it be, is the modality which picks up fatty liver at its first stage, or is the first modality which tells us or alerts us that this patient is fatty. Just for the sake of it, today, when I just wanted to count the number of reports of the patients whom we reported as fatty liver in one day. And this is the first time I did this exercise, but I'll urge Rajesh to continue with this, that in today, 10 to 12% of our patients reported from ultrasound center for various reasons. They were referred for various reasons. 10 to 12% had fatty liver. And I think if we keep a watch, it might be even more. So in a day-to-day practice, what picks up fatty liver is a routine ultrasound, because that is what is done everywhere. It is available everywhere in every nook and corner of the country. And it is very good for conventional ultrasound to pick up severe degrees of fatty liver or even a moderate degree of fatty liver. Where it may have its problem is picking up mild hepatosteatosis. And therefore, the overall sensitivity specificity goes down. But we cannot just ignore routine ultrasound. That is where we are going to pick it up, especially when we want to screen the population. So this is how the normal liver looks like. That's how a fatty liver looks like with increased reflectivity. And we commonly compare the liver to the kidney to pick up a fatty liver. Based on the ultrasound appearance, we can also grade the steatosis, and we have been doing it for years. So that's a none, that's a mild hepatic fatty infiltration, that's a moderate one where you're not able to see the vessels so well, and that's a very severe one where you're not only not seeing the vessels, but we're not even seeing the distant diaphragm. We very often practice see things like focal fatty changes in the liver, which appear as hyperreflective areas, and fat spared areas, which are seen as eco-poor areas. But it is very important that we use the right set of machines. Here, for example, we are doing a conventional ultrasound and the liver looks quite okay. But when we use a higher frequency probe, we see that this liver has irregular margins, and we can see the nodules of cirrhosis as well. So at least in our center, and those who learn from me and our center, basically we always look at a liver not only with a conventional probe, but always with a high frequency probe, because we can pick up changes like this very well. So the advantages of a routine ultrasound are easy availability, portability, non-invasiveness, and of course the low cost, well accepted by the patients. If you look at the cost of MR or something like that, you really cannot compare this. And therefore, by far and large, when we are talking of screening the population, this is still going to be the modality, though there are limitations like inter-observer variability, subjective sort of nature when it comes to reporting, less sensitivity for picking of mild steatosis. There can be a little overlap, of course. There can be other technical factors, but when it comes to mass screening, today we pick up fatty liver on ultrasound, and then the patient goes for something else. Today we had 2 diabetic patients who had come for something else, and they had a fatty liver. So that's where Bhushan is going to be now alert. One of them is Bhushan's patient. So tomorrow when he goes to Bhushan's OPD, he's going to look at him from an entirely different perspective, because we have picked up a fatty liver, and that is the role of conventional ultrasound. But we want to quantify, we want to go ahead, and we now have various techniques, out of which, of course, CAP is a technique which is non-imaging, and we'll point out the limitations of that. There are 3 techniques in ultrasound which have come up. One is the hepatorenal index, attenuation coefficient, and the speed of sound. Besides that, there are various other techniques which are under research, and a combination of these techniques are also being used typically to pick up inflammation. So ultrasound techniques which can now quantify fat and pick up fat again will become popular in a few more years because of availability. Because it is the same machine and you have to just upgrade your software, of course, at a cost, and it is still going to be much cheaper as compared to the techniques like MR. And we are going to quantify, and I'll show you slides of quantification as well. So transient elastography now has a method of picking up fat, and that is known as CAP. And basically this is, as Bhushan said, has a lot of limitations. It is a non-imaging technique. You don't know what you are looking at. You don't know whether there's a liver there. If the patient has something like dextrocardia and with cytosine versus, you may be looking at a spleen fall, you know. You don't know whether you're looking at a mass or you're looking at gallbladder, you're looking at vessels. So for all practical purposes, I mean, as an imaging person, I would not recommend this technique at all. So coming to ultrasound-based techniques, there are 3 techniques. One is the hepatorenal index, second is attenuation, and the third is the speed of sound. The hepatorenal index is something very simple, and it is based on liver to kidney cortex echogenicity ratio. So what we do is put a marker in the renal cortex between the pyramids and put another marker, or we take one more measurement in the liver at the same depth. And typically the machine gives us HRI, or the hepatorenal index, which typically for all practical purposes is always less than 1 in normal individuals. And typically in patients with fatty liver, it goes beyond 1.28 or 1.3, and more the value, more is the degree of fatty liver. This is something which is very easily done. And what is more important, that this has got a very high degree of accuracy. So it's a very simple method with a very good degree of accuracy, and it is not affected by other compounding factors. But where it lacks problems, where the problems can come up, is because little bit of subjectivity, and the most important is it is still lacking validation, which probably will come up in the next few years. One more factor, which is a limitation as far as HRI is concerned, is that if the patient has, say, an associated renal disease where the kidney is small or echogenic, we are definitely not going to use this, but we know that this kidney is disease and will not use in that particular patient. The technique which is most popular as far as not only picking up fat, but also quantifying fat is attenuation coefficient. Now, this attenuation coefficient is done by using an imaging ultrasound machine like the one of Mindray, which we are seeing on the screen as of here. So what is this? Now, basically, when we do a conventional ultrasound, as the beam traverses from the anterior capsule of the liver to the posterior capsule of the liver or the diaphragm, there is an attenuation of beam, which is normal. But because we want to see a uniform picture of the liver, in our machines, we have a device which is known as TGC, or a time gain compensation, which makes the picture uniform. But whenever there is a fat, this attenuation, which is normal here, is much more significant as compared to a normal attenuation. And what we can do is compare the attenuation by a fatty liver to that of what is expected in a normal population. And this difference gives us an attenuation coefficient. And by far and large, this is the most popular way of estimating fat. So this is how it works. We have sort of, once you put on the patients, we just click one button, we get two sort of boxes, one which tells us about the fat and one which tells us about the confidence map or how accurate we are. And typically, if you look at this map, if you have darker blue color, it is something which is normal, and lighter shades of blue, or for that matter, if you have a map like this, then lighter shades of blue, green, or red are something which are fatty. So typically, if you look at the values, they are usually less than 0.6 decibels per centimeter per megahertz, etc. And typically, but when you have a fatty liver, these values typically go up to 0.7 or definitely go above 0.66. And higher the value, more is the degree of the fatty liver. So by far and large, usually a value of 0.66 is considered as a threshold to differentiate. And with this cutoffs, that is, if you are consider anything which is below 0.59 as rules out significant steatosis, anything which is above 0.7 rules in significant steatosis, we have a very high degree of accuracy, both in terms of sensitivity and specificity. And then, of course, what is most important is that we can segregate out or pick up significant steatosis versus one which is not significant. And that is what we are looking at. So we also have values of cutoff, which can tell us, say, the difference between S1, S2, and S3. But again, this we need much more studies for this. But I think in the next 1 or 2 years, this will be more standardized as well. One of the problems which, as far as attenuation is concerned, and as far as fat estimation or quantification is concerned, is that different vendors have different techniques as of today. And the cutoffs also may differ from with different vendors. These are just three sort of examples of different vendors who are using different techniques. But in the coming few years, this will be standardized. In fact, maybe in the next year. And the same thing happened to elastography many years back. But as of today, elastography is absolutely standardized, and the degree of accuracy is absolutely very fantastic. The third way we can look at fat is by what is known as speed of sound. Now we know that the speed of sound decreases again proportionally to the increased liver fat content. So what we do is measure the speed of sound as it traverses from the anterior capsule to the posterior surface of the liver, with the basic principle that higher the fat content, more is the attenuation of sound, and slower is the propagation of sound. So typically sound speeds which are going well below 1.1537 or 1530 meters per second are considered as significant. And this again has a fairly good sensitivity as well as a specificity in picking up fatty liver. Let's come to inflammation. Can ultrasound pick up inflammation? Which I think is the burning question which Bhushan has every time he sees a patient with fatty liver. So I would say that as of today, there are new techniques which have been explored which are based on combination of various ultrasound factors like acoustic impedance mismatch, the backscatter, the attenuation, etc. Now, for all practical purposes, when we have been doing ultrasound for years, there is so much information coming from the ultrasound machine, and basically we are not using all that machine information. But today, because of the technology, like Dr. Mr. Eckerman told us, we are picking up anything which was wasted all these years, and we are trying to put things together. And one such area where we are putting things together is to try to pick up inflammation. And one vendor has come out with what is known as a viscosity index, which is based on viscosity. And typically, again, the technique is very similar. We have two boxes, one which tells us about the quality, one which tells us about the actual values, and then we have scores of viscosity. The higher the score, the higher is the inflammation, typically something above 1.8. And Rajesh and me have been using this machine, and we have been giving feedback to the clinicians. But as I said, that this is something which is still needs to be standardized. So anything where there's an acute inflammation, maybe like something like an acute hepatitis, or for that matter, NASH, we can pick up with this particular way, but we need more studies on that. What is established definitely as of today, and I would definitely challenge you on the fact that MRI is the one-stop shop. No, when it comes to liver fibrosis today, ultrasound is absolutely accurate, because we have so many studies and we have standardization, we have guidelines. So, it is a very well established, and I just hope you know that we were the first to start looking for liver fibrosis many years back, almost first in Asia. And I think we have a well established thing there. So again, here Fibroscan is what, as Bhushan said, is for me is something which is no. It's a non-imaging technique, and you really don't know what you're doing. MR definitely has a big advantage in the sense that you're looking at a larger perspective. You're looking at the entire liver, and you have a wonderful talk. She's a wonderful speaker. But how many times are we going to do it? Are we going to repeat it? Is the patient willing to spend that much money? Are we going to screen the population with this? And is it available everywhere? Is that expertise available everywhere? That's the problem. And that's where I think ultrasound plays a very important role. And in shear wave technology, what we are doing is we are doing a real-time B mode. As Bhushan said, we have an advantage of doing a B mode. Look at liver, look at complications, ascites, portal hypertension, pick up the area of interest and actually measure it. So what are shear waves? Basically, if you put a stone in water or just sort of put your finger in water, you get waves, right? And the velocity of these waves as they travel through the water would largely depend upon the density of the water. So if you have a water or something like an oil, the speed would be different from the speed of, say, when you put a stone in the water. If you have something like a melted gold or something of that sort, the speed will be different. And that's what ultrasound does. So what we do basically is put in an ultrasound beam which basically generates shear waves. And as this shear wave travel through the liver, they are picked up by another pulse, which is known as a detection pulse. And this detection pulse actually measures the velocity of the shear wave with the basic funda that normal liver is viscous and does not favor the propagation of the waves. Once there is fibrosis, there is increased hardness, and this favors rapid propagation, and therefore the speed which we can measure of the shear wave goes on increasing. There are two ways we can do it. One is what is known as a point shear wave, and the other is what is known as a 2D real-time shear wave. Point shear wave is we look at only one area in the liver. This has limitations in the sense that we're not looking at a larger area, whereas in a 2D real-time shear wave, we look at a very large area. That's the difference. We are looking in a point shear wave at a small area, whereas with 2D real-time, we are looking at a larger area, and we also have something known as a confidence map. So point shear wave is something which we started many years back, and we get the values good enough. And in some of the vendors, we have this sort of a dial. And I always use this dial when we have alcoholic patients who come to me. Non-alcoholic is a different issue altogether. But when we have alcoholic patients who come for follow-up, I show this dial. And I say, hey, guy, today this mark is somewhere here. Be careful. Once it comes and crosses this line, you are going to have problems, because he doesn't understand kilopascals. He doesn't understand meters. But if you show him something like a dial and say, okay, as long as you are up to this point, okay, we can do something for you. Once you go beyond this, we cannot do anything for you. So that's good for the layman. Coming to 2D real time, where we have two boxes. One is a confidence box, and one is, of course, your box. And typically, higher the degree of fibrosis, we see different shades of blue, or we see green, yellow, or even red. So, more the degree of fibrosis or cirrhosis, we go from blue to dark red, and that's very easy to interpret. And of course, we can measure wherever we want to. And typically, here again, we can grade the fibrosis based on the meters per second, which correlates very well with the metabolic score, and as well as the clinical entities like mild and advanced fibrosis. But there is, in medicine, we know there is an overlap, and therefore we have recent guidelines from the SRU, which were published a couple of years back, which are standardized now, and we use them in practice. And this is known as the rule of 4. So typically, every time you add 4 to the basic kilopascals, we have a higher degree of fibrosis, and we can interpret it accordingly. And this can be shared with not everyone. So again, this does very well in picking up fibrosis, grading fibrosis, and most important is picking up clinically significant fibrosis. So as compared to transient elastography, as Bhushan said, this is much more accurate, not influenced by body mass and index and ascites. We have an anatomical guidance, no technical failure. It is reproducible very easily, and of course, we can stage fibrosis based on that. So in the coming years, and today we have already started doing this in our center, we will give you an integrated report. I mean, patient comes for ultrasound, of course. Besides the routine ultrasound, we will give you an idea whether the patient has fat by the attenuation coefficient, as well as speed of sound. We may give you an idea about inflammation based on viscosity plus, which is still sort of, I would say, in a budding state. And then, of course, we can confidently tell you whether there is a fibrosis and how much is the degree of fibrosis. Follow-up, very important. And here again, I would say that ultrasound is going to remain the modality of choice for follow-up because of availability and because of cost. It may not be practically easy to go on doing MRI in 6 months or a year for that matter, because of so many reasons. So ultrasound techniques, easy to perform, OPD, no time factor, very easy, just a matter of 5 minutes, very easily reproducible, availability, most important, cost, and easy to follow up. What is the problem is the awareness, and I think IRIA is the right thing, right? IRIA done the right thing by having this platform, and we now have an excellent teamwork between GI, and I think all the clinicians will jump at this sort of cooperative effort from all of us. Standardization especially is required still as far as fatty liver is concerned. Elastography, as far as elastography is concerned, everything is standardized as of today, and this will be done in the next few years. And of course, reporting structures also need to be structured. Again, IRI can play a very important role there. So we have we have been talking today that we need to pick up things at an early stage. And I think imaging techniques and ultrasound in particular is going to play a big role as far as the national schemes are concerned at a very large level in a population like India. Thank you so much.
Thank you, Chaubal sir, for that extensive description of this scenario with which ultrasound can be used for fatty assessment and liver fibrosis assessment, and as a screening tool, the importance of ultrasound, especially the 2D shear wave elastography as a screening tool to help clinicians to quantify fibrosis in the current scenario, that has been well explained. We have set had the program in such a way that the liver disease burden was explained by Dr. Praveen Nermalin, the clinical perspective of NAFLD, fatty liver, the NASH and the cirrhosis, everything, and the approach towards that by a clinician with the help of laboratory investigations and imaging parameters were described by Dr. Bhushan. And then MR elastography and the role of MRI, which has got a higher specificity, but may not be as good to use as a screening tool, because of course MR has got a lot of advantages in terms of comprehensitivity. And now Chaubal sir has explained the role of ultrasound, which can give multiple parameters with the very important role of 2D shear wave elastography playing a giving critical information for the clinicians to act upon and the patients to have the treatment advice. Then Now we are going into the real stuff. The National Academic Lead of Preventive Radiology on NAFLD and NASH, Dr. Rajesh Chaubal, will be talking to us on. Most of the people who are joined here, I assume, are radiologists who are keen on practicing ultrasound elastography, especially the 2D shear wave elastography, with some of the new equipments and technologies that Mindray has now come out with. And I hope, I'm sure Rajesh will be highlighting some of this sonography technology of Mindray and all, especially the reliability index, the motion stability index, because it is, those things are interoperative differences, and the chances of errors has to be much less when we do the elastography studies. So I invite Dr. Rajesh Chaubal to give a case-based evaluation and the techniques on liver elastography, and that will be the final session of the day. And I'm sure we will have more similar sessions with a larger perspective, larger insights being added by different disciplines. Let me invite Dr. Rajesh Chaubal, the National Academic Lead for Preventive Radiology in NASH and NAFLD. Over to you, Rajesh.
Thank you so much, sir, for that kind introduction and having me over here. Am I audible? This is visible?
It is visible. It is visible.
Yeah, okay, fine. Great. Okay, so I think my job is simplified by all the eminent speakers before me. I'm not going to go into any of the disease process or the details. What I am going to focus on the technique of doing the elastography studies and doing these fatty liver assessment studies. And why this is so important is because what we are finally looking at is the reliability and the reproducibility of our ultrasound techniques. It's only when we are sure of our techniques, our reproducibilities, it's only then that clinicians like Dr. Bhushan Pandit are going to be more certain with what we are doing, and definitely we're going to increase this interactive cooperation between the two specialities. So having said that, let's see what we can do to really have a good imaging for our elastography and fatty liver assessment. So first and foremost, whenever a patient comes to us, we don't blindly going ahead with our elastography studies. It's always a good idea to just understand, take a quick history, try to understand what type of disease we are looking at, look at the laboratory reports, have a quick B mode survey. Even if the patient they've not asked for a portal Doppler or a full abdomen study, have a quick look. That's the advantage of ultrasound. You don't really need to take too much of an effort to have a look at different things. So you can just take a quick look at everything. Like sir said, have a look with the linear probe, and we need to rule out things like congestive failure and maybe even an acute hepatitis, because these can be confounding factors, as I will show you later on. Ideally, when we do a elastography study, we would want the patient to be fasting for 6 hours, because if the patient is non-fasting, we can have falsely elevated values. Then also, when before we take the patient in for our study, it's always better to rest the patient for say about 10 minutes or so, because we don't want to have someone who's just run up the stairs and directly come onto your table and do the elastography study. So how do we position the patient? We ideally keep them in a decubitus or a semi-decubitus position. We like to keep the hand above the head over here, so that what happens with this is we are increasing the intercostal space. And once we increase the intercostal space, we got a good area to image, because we need to absolutely get a wonderful 2D image. If we don't get a good 2D image, we are not going to get good elastography readings. Right? Before we start with the study, it's also very important to explain to the patient what is a shallow breath hold. We don't want the patient to take very deep breaths in or out. We just want them to do a shallow breath hold. So just hold the breath in between inspiration and expiration, and that is the ideal way to take your measurements. So all this should be done before we start going ahead with our readings. So like I said, getting a good B mode is very important. We do not want rib shadowing to be coming up like this. We want a good image of the liver. So it's always a very good idea to do an intercostal scan And when we position the patient well, we should get a very clear, nice image like this. Also, we do not want to go very close to the diaphragm because there will be reverberation artifacts coming up over here, and we do not want to take up any measurements in this area. Also, what we do is do not image in the left lobe. We do not take our values in the left lobe. Why? Because you will have the cardiac pulsations coming up over there and interfering with your values. So again, sir has already mentioned, we have different types of elastography. We have a point shear wave, we have a 2D shear wave, and all the different vendors will have their own different terminology for these techniques. So in a Mindray language, point shear wave is called as sound touch quantification. So what happens with a point shear wave is that you have this small box, say about 0.5 to 1 centimeter square. And this is the box which is going to be used for measuring your elastography values. So where do you position this box? So number one is the lobe. We already said we do not want to go into the left lobe. We do go into the right lobe. We choose anywhere between a segment 5, 7, 8. Anything is absolutely fine. This is all as per the SRU guidelines. We want to ideally keep this box, say about 4 to 5 centimeters depth from the transducer. So that translates roughly at about 2 centimeters below the capsule. And this helps in avoiding reverberation artifacts coming from the capsule. And again, I'm going to focus on this. I'm going to mention this. We have to optimize our grayscale. We have to get a good B-mode image. Otherwise, we are going to have problems with our readings. And when you place this box, you have to make sure that the box is absolutely perpendicular to your imaging. So we look at these 3 lines. We look at the surface of the probe. We look at the surface of the liver, and we look at the top of this box. And all 3 should be absolutely parallel to each other. This is how we establish that the box is perpendicular to the probe. And when we place this box, we want to ensure that we are not keeping it anywhere within the large vessels or large biliary radicals. We do not want it to be at an angulation. And make sure this is again not going too close to the diaphragm. We are not going into the rib shadowing area. And of course, we like I've said, we want to have the patient with a shallow breath hold when we do the assessment, when we take our measurements, which we have to explain to the patient prior to starting the study. And once we start the study, we can take values at the same spot also. So we want 10 spots, 10 readings when it comes to point shear wave. That is as per the SRU guidelines. And even if you take it at the same spot, it's perfectly fine. It doesn't really matter because we are trying to assess diffuse liver diseases. You can measure in kilopascals as well as meters per second. The majority of the machines nowadays will give you values in both, so it's absolutely fine. You can give your report out in whichever format you and your consultant is comfortable with. Now, one of the there are different techniques which are being brought up by different vendors, and this Mindray machine, the Resona i9, we really have some very interesting features. I'll show it to you as the presentation progresses. One of them is that we can actually increase or decrease the size of the point shear wave box, which is not available with the other vendors. And the reason this helps us is you can really place your box in a place where the vessels are not there, where large biliary radicals are not there, and with that you're increasing your confidence of getting good values. The other thing is that the other advantage of this machine is that we can actually obtain multiple readings at the same site in a single breath hold. This is also something which I have not encountered with any other vendors. And this is very useful because what happens is that if you have a patient who has a difficulty in breath holding, you can take multiple readings very quickly and complete your study much faster. So you can get these values. All these different bars will indicate the different values which are which have come up for every reading in every frame. Now coming to the 2D shear wave, which is a much evolved technology over the point shear wave, and we have been using this for the last 4 or 5 years with actually excellent results. Pardon me, I'm having some difficulty with my videos. I'm going to just start it again. Okay, The advantage over here is that you can have a box with a larger region of interest. And again, the way that helps you is that you can actually take multiple readings in a single shot, right? And the way you place this box is very similar to the way we did it with the point shear wave. It has to be 2 centimeters below the capsule, avoid large vessels and large biliary radicals. But when you have a large box, when it comes to a 2D shear wave, it may be difficult to avoid vessels, but it doesn't really matter. And I will show you why in the next couple of slides. So we have the ability to adjust the size of this elastography box. And this box over here on the right hand side is what is going to give you your elastography reading. So it fills up with, this colors. So blue is something which is normal or softer, and red, or as you go towards yellow and towards red, you are actually looking at increasing stiffness. So on the right hand side, what you have is your elastography reading map, and on the left hand side you have your reliability index, or what can also can be called as a confidence map. Now the way this is of advantage in 2D shear wave is that when you take a particular reading, right, you can try and at the same time look at the box on the left hand side of your screen and look at the reliability of your reading. Okay, so this reliability index pops up over here. In this case, it's 100%. You want something at least more than 80% before you go ahead and take your readings. So this is something which increases our confidence of taking better readings. So this is something that we always must have when we when we have this option available with us. We definitely have to use this without any doubt. So like I said, we are able to adjust the size of this box. Once we ask the patient to breath hold, we should wait for a few seconds for the image to stabilize, right? So give it a few seconds, you'll get a good nice color filling. And after that, what you do is you place these calipers. Okay, you can place these small calipers within the box where you think the vessel is completely not coming in, or where your reliability is very good. Again, green over here indicates a very good reliability, and you will get your corresponding readings for these calipers on the right hand side of your screen. So the advantage, like I said, is you can take multiple readings in a single breath hold or a single shot. So we can potentially take 3 or even 4 readings in a box, but it may be advisable to restrict yourself to 2 readings or so within a particular box, because for any reason, if there is an error which has cropped up in your technique, it shouldn't reflect in your multiple readings. So what we typically do is take maybe 4 or 5 boxes and take these multiple 2 or at the most 3 readings within a single box, and then we use these for our interpretation later on. Now, the other wonderful thing which we have, with this Mindray system, the Resona system, is the availability of this motion stability index. And this is extremely useful when the patients are non-cooperative, or you're probably looking at admitted patients, or you're looking at kids, or you're looking at someone who is having a lot of difficulty in breath hold. And what this helps us to do is try and understand in which frame the motion is relatively lesser, right? So it will give you better results. So if you look at these couple of images, you'll see that in these couple of frames, initially the motion, there's quite a lot of motion. So you're getting a score of maybe 2 or 3 stars, whereas you want something which is more stable, so you get 4 or 5 stars. So the moment you know that you have these 4 or 5 stars popping up over here, where your your motion stability index is indicating, that yes, this is a good place for me to take this image. So similarly over here, you can see that this box is completely purple. You have just 1 or 2 stars, which is indicating that this is there's 2 stars over here, so indicating a very poor motion. And at the same time, you look at your reliability box, it's almost purple, so which is showing a reliability of index of only 2%. So what this means is this is not an image where you want to take your readings. If you take your readings in this image, there's a good chance that something will go haywire later on. And yes, I've already discussed with you the implications of the reliability index, which is there on the left side. So you want it to be completely green as far as possible. And you want it to, if you look at the value, you want it to be at least more than 80% before you go ahead and take your readings. Now, the other feature which is available in this system is something called as a high quality elastography or HD elastography. What happens with this is, we saw Mr. Ekambram's presentation where he showed that how the elastography in this machine is getting acquired at a very high frame rate, so it doesn't really hamper your beam mode readings. But at times what happens is that the imaging may be difficult, the patient may be uncooperative. So you may have these few seconds where you want to gather a good bit of information, and that is where you can use this high quality elastography that within where in a single frame you get more data, you get better quality of your elastography readings, and you can use this for your interpretation. So a couple of things that you want to be careful of when you're taking your readings. You want to ensure that you're not going too close to the capsule. You want to ensure that you're not going too close to the diaphragm. That will cause reverberation artifacts. You can see that your reliability index has dropped down to nearly 30%, and this is not somewhere where you want to take your readings. Of course, don't go too close to vessels, but as you can see, when your box is big, the vessels will definitely pop up. But if you look at your reliability map over here, you can see that the machine is showing you that these areas are purple. So when you place your caliper, you do not want to place the caliper in these purple areas. You want to place it only in these areas which are green and show absolutely good filling of the elastography box. So at times you may get non-filling of the box, and you have to be very careful in these situations. You may, this at times you encounter with cirrhotic livers when the liver is very small. You cannot make a box which is very large. So at that time, you have to use these advantages of the 2D shear wave that you have. Try and make the box a little smaller. Even if you get a single reading per box, it's good enough. But what you want to try and strive to achieve is your accuracy. So once we have taken your maybe your 6, 10, 8, whatever 10 readings that you have taken, we want to go back to our report page for analysis. And what is the value? What are the markers that we are looking at? So number one, for your interpretation, what we are looking at is the median value. Like I said, the machine will display it to you in kilopascals as well as meter per second. You can report both. And this median value is what you are going to be using for your interpretation. And when you look at this median value, you also look at something called as IQR upon median value, which comes up, which in terms of kilopascal should be less than 30%. And in terms of meters per second, it should be less than 15%. And what this helps you to do is, again, get a good qualitative assessment of how good your study has been. So you want your IQR upon median to be as close to 0 as possible. If you get this value to 0, you have done an absolutely brilliant job, and you're very sure that the way you've done your study is absolutely great. So in this machine, we also have the option of not calculating values where the thing is a little off. So you can use this also while analyzing your reports. If you think some values are way off the range, you may want to eliminate it. Now, one way is that, this is a question just frequently asked: if I have these multiple varying values, which ones do I not consider? Well, the values which you should not consider is the ones which are increasing your IQR upon median, or that there's some kind of a confounding factor which is popped in, your reliability is poor in that box. Those are the ones you should skip. Don't necessarily look at the values. So suppose I'm looking at this kind of a picture, majority of the values are around this 2.3 figure, 2.3 figure, and so should I take all these values which are 1.4? Not necessarily, unless you go back to it and see that yes, there's some kind of a problem with the image, and then you may not want to consider these images for calculating your median values. So just a quick look again, look at this IQR upon median value. It should be less than 30% when you're looking at kilopascals, less than 15% when you're looking at meters per second. So this is a very nicely done study where all the criteria are fitting in. Whereas if you look over here, it's a very horribly done study where you can see that the IQR upon median is going to 52%. So this is not a kind of study you want to report with. We have already discussed the rule of 4 and a couple of sources which creep in when you are looking at elastography. One is there is a little bit of a difference when you're looking at hepatitis B or hepatitis C or non-alcoholic fatty liver disease, though now the difference is not so significant for you to be reporting in terms of different diseases as such. So we can use as standard cutoffs for hepatitis B, C and non-alcoholic fatty liver diseases as well. Like I said, it's always a good idea that we have to, take a quick history of the patient, look at the background things, because if you have something like a congestive heart failure or a cholestasis or a acute on chronic liver disease, these can falsely elevate your values. You may not be able to really, pinpoint something accurately. And now, again, the modality being used. Now, we do not want to compare shear wave elastography with a MR elastography. So if a patient is coming to me today for doing an ultrasound and having done a MR previously, and I'm asked to compare between an MR and the ultrasound, it's not the right thing to do. I should not be doing that. If the study is done on a particular modality, it should be followed up with that particular modality only, because the way in which the elastography is acquired is very different. So those kilopascals will not really, correlate with your ultrasound. Now the system specific factors and machine specific factors have gone down dramatically with the help of the Kiba RSNA platform, which they've really strived to bring all the manufacturers on a single page. So in fact, now the variability between the manufacturers is just about 10%. Obesity and ascites honestly doesn't make too much of a difference nowadays, unless the patient is so obese that you're not able to get a B-mode image. But if you ask me how many times does this really happen, well, it's very, very rarely that we really encounter this. Then of course we do not want to see the patient in the postprandial phase, so we want the patient to be fasting. And like I said, explaining breath hold to the patient is very important, because if the patient does something like a Valsalva maneuver, it's going to increase the stiffness values of the liver. So the commonly encountered problems that we see are the presence of congestive cardiac failure. You can see that the hepatic veins are dilated, IVC is non-collapsible. So this is going to falsely elevate your values. And when we have some acute flares of hepatitis, again, I'll show an example of this a little later. So now now that we have seen the assessment of fibrosis, I'll quickly go over the assessment of steatosis, how we should do it. Like sir has explained, we have two things which are available right now. We have the hepatorenal index and the attenuation. In terms of the attenuation, we can also see the speed of sound. So first, coming to the hepatorenal index, it's a very simple thing. It's just the brightness of the liver compared to the brightness of the kidney. So once we go into our settings of the hepatorenal hepatorenal index in the machine will directly prompt you to place one cursor within the liver and one cursor within the kidney. Different machines work differently. So some want you to place the caliper first within the kidney, some would want you to place within the liver. It doesn't really matter. You just go by whatever machine you have. What you have to ensure is that make sure there's no artifact in the area which you're imaging. Make sure that they are imaged at the same depth. And some of the studies which have come up nowadays say that in fact you should not place it in the mid region of the kidney. It's always better to place it towards the pole, because you go a little further away from the capsule and you're reducing the reflectivity which is coming from the capsule. So that is also something that we have started doing recently. We have seen already the cutoff values. I'm not going to brood over that. Now coming to the attenuation and the speed of sound. So like we've seen, there are different ways of measuring fat that we have on ultrasound currently. We can estimate the speed of sound, we can estimate the attenuation, and attenuation is what is available on majority of the systems at this point of time, and with which we can classify whether the liver is fatty or no. So there are a couple of differences when it comes to doing this study as compared to an elastography study. Number one is, in this we want to keep the box as large as possible because we want to get a larger volume of the liver. The box is ideally works a little better when it's at a better depth as compared to elastography. So this the elastography box you won't want to keep maybe about 2 centimeters below the capsule. Here you'll probably start somewhere below 4-5 centimeters below the capsule. Though this does become a little challenging, especially when the livers are a little small. And unlike elastography, where we have said that the box has to be absolutely parallel to the liver capsule. Here, in fact, if you give a little bit of angulation, what we've seen is that the images that we get and the values that we get are a little better. Though what I would want to say over here is that unlike elastography, where we have very well established guidelines by the SRU and multiple societies, as matter stands, we do not have adequate guidelines on this. There's a lot of work going on at different corners of the world, and hopefully maybe towards the end of the year or something like that, we may have a better idea of how to do it. But that should not be stopping us from going ahead with these studies. We should, do these studies as much as possible. And, all of us are on a learning curve. The same thing happened with elastography. Initially, we came out, we were very confused at, how we should do it, where we should do it, and, what on and what not. And there were a lot of, we were not getting good reproducibility. But over a period of time, things have definitely improved dramatically. And I would say the same thing about attenuation. It's, I think, just a matter of time before we get much nicer and better data. Again, I'm not going to go over the thresholds. As far as inflammation is concerned, we have seen this in one of the systems. Again, nothing very different. You just keep the box the same way we did on elastography, and hopefully we should get good filling. So I'll just show a few cases of what we encounter very normally on our routine practice. This was the OPD patient who just walked in, and on B mode, the liver was looking a little fatty. When we applied liver attenuation, yes, definitely there's a fatty liver. You see that the box is slightly tilted as compared to our elastography box, which is absolutely perpendicular. But the attenuation values were suggestive of fatty liver, but there was no presence of fibrosis. In this case, there was definitely a fatty liver. You can see that the attenuation values are ranging in the range of about 0.7 plus, and the elastography values were suggestive of a compensated advanced liver disease. Now, these are where you're looking at median values of roughly around, say, 1.9 closing into 2. Now, these are the patients which can potentially have a NASH, though at this stage it's very difficult to state. But what we can definitely say is definitely there's a component of advanced fibrosis, and this is suggestive of a compensated advanced liver disease. Now, what is very important is when these patients come for follow-up, like Dr. Pandit was saying, we need to have some kind of a way to measure or estimate that whatever therapy they have been on, how well it's working and how well it's not working. So ultrasound provides us a beautiful setup for following up these cases. What you should do in these cases is you do not go on grading them every stage they come to you at, right? So once the patient comes to you the first time, you say, you maybe grade the patient, you say maybe there's a F3, or you maybe say this is a compensated advanced liver disease. And now when the patient comes to you for follow-up, you go on comparing these values as compared to what they were previously. And all you need to assess is something what we call as a delta change. So what we call as a delta change, or what we call as a significant change, is when there is a change of more than 10%, right? So if these values are dropping more than 10% compared to the previous scan, I would say that yes, this is definitely significant. And the reason for this, as cited by Kiba and RSNA, is that the variability between the machines now is less than 10%, right? So irrespective of the system that you're using, if you get a value drop of more than or increase of more than 10%, then you're looking at a significant change in your value. And one thing which is ideally, if possible, these repeat studies have to be done on the same machine and as far as possible by the same operator. So you're reducing all possible confounding factors. And this is the kind of thing that we use in children as well. We do see a lot of these cases with, say, even iron overload in thalassemia. They have been coming to us for follow-up. So we do not assess the level of fibrosis in them. What we say is that how is it progressing? Is it worsening or is it getting better? So here was a case where we saw that this was a fatty liver. You had a value of about mean stiffness about 1.5. So this is still in absence of other signs ruling out a compensated advanced liver disease. But when the patient has come to you again, almost say 7-8 months down the line, you can see that these values have increased. You're looking at roughly about 1.7, 1.8. So there is a definite change in these values. These have definitely increased. And yes, this can again be someone who is going into NASH. On the other hand, this was a fatty liver patient over here who was, again following up with us, and these values, he was on a diet and he was doing quite well. So in fact, you can see that the values have dropped from somewhere around 1.9 to 1.6. So he's definitely going on the right path. Now, very interesting. This was a lady, I think she was about 50 years or so, who came to us in September, and she was post-COVID, and immediately after COVID, her liver enzymes had shot up. They were persistently remaining high, and we saw that these values were coming in the range of about 2 or so. But we were not very sure. There was no other sign of advanced liver disease in this patient, and because this had happened only post COVID, so we gave it a benefit of doubt. We said that this may just be because of an acute inflammation, and we followed her about a month and a half down, and what we saw that the livers the values had actually come down, and so had a liver enzyme. So keeping all these things in mind, so it would be very wrong to label this patient as a fibrosis or advanced fibrosis. She was definitely these values were just high because of an acute flare. So you have to keep all these things in mind, and once we followed it up, you can see that this has definitely gone down. So don't forget, the whole idea is don't forget the clinical picture when you're going and when you're doing your elastography studies. Don't just interpret the values. You look at the entire setup and interpret your case. Thank you so much.
Thank you. Thank you, Dr. Rajesh Chaubal, the National Academic Lead of Preventive Radiology, for giving that elaborate lecture on how to do ultrasound elastography. And I think we have had a very extensive session here, and there were lots of questions. I think all the speakers have answered it in the boxes. Since we are short of time, I think it is better we wind up because we have exceeded nearly 1 hour, and we will have more of these sessions as planned by the Preventive Radiology Committee. We have partnered with Mindray. We have got 12 offline sessions coming up with workshops and training programs at 12 different states in the next 2 years. And apart from that, those centers which are interested to be part of this multi-centric study, where we will be validating we'll be comparing the results of 2D shear wave elastography of the Resina I9 machine with Fibroscan, MR elastography, and biopsy. Those centers which would like to participate, the expression of interest letter, this thing will be sent by IRIA soon, and the state chapters will also receive the guidelines for bidding for the CMEs on preventive radiology, especially on preventing NAFLD and NASH. So there are a lot of training programs, skill enhancement programs, and multi-centric research activities coming up. And thanks to Mindray for partnering for that effort with IRIA. And we are going to have a lot of data from our Indian population on this particular disease. So with that, I would like to thank all the speakers, all the faculties. Dr. Bhushan Pandit was the Sachin Tendulkar from the clinical
Mumbai.
specialty who has joined us.
And from Mumbai.
Thank you, sir, for that nice perspectives you have shared with us, and we will continue to have your association with us because from the clinical radiology perspective, we are looking into a larger picture of a community screening and in the preventive radiology aspect, and NAFLD, of course, it's a big teamwork that is required for that. Thank you very much, sir. Thank you, Dr. Nitin Chaubal, sir, for that, for your participation and guidance. And Dr. Rajesh Chaubal has formulated this program, and as a national academic lead, he will be playing a very important role in the scheme of preventive radiology as far as NAFLD is concerned.
And I have to thank Dr. Rijo for spearheading this program and really, inspiring and guiding all of us. I think without that, you need the right direction. Otherwise, you're aimless. So thank you so much.
Thank you.
Absolutely. Absolutely, sir.
Absolutely,
sir. I think on behalf of Mindray, let me really say it was one of the most important landmark day for Mindray, especially for Dr. Rijo, for spearheading a program which is so interesting from a holistic, clinical as well as multimodality point. We are really honored Dr. Nitin Chaubal and Dr. Rajesh Chaubal and other speakers like Dr. Bhushan participated along with Dr. Praveen Nermalin and Dr. Ritu Kashkar. Thank you. It's a really great pleasure to be part of this program, sir.
Thank you.
Thank you. Good night. Thank you, sir.
Thank you. Thank you, sir.
Thank you, Mindray and the technical team.
Thank you, Mindray.
Thank you, sir. Thank you, sir. Thank you. We are
some people have asked for reporting format, so we will share. Rajesh will share it with you.
So,
Mr. Ekambram, would you have like a list of your the attendees or something? We can probably mail them, and if they have any queries, if they have any queries, you can probably coordinate between them and me. I'm more than happy to answer any queries or anything that they have. Yeah.
Absolutely, sir. We will follow it up with the questions which are still not answered, and we will forward to all the speakers to revert back. We will take care of it.
I am looking forward for more interaction with you guys.
Absolutely, absolutely.
And I'll see you
glad to have you.
Dr. Rijo, I'll see you in Cochin definitely one day.
Oh, yes.
Thank you, Chaubal, sir. Thank you for this opportunity.
The gastroenterologist, Dr. Anthony was already mentioned about. Sir, this Egambram, this telecast with this will be available in YouTube, no?
Absolutely, sir. We will put it on the
today's this session will be able to listen to it. It will be soon available in YouTube, and Mindray will do.
Please share the link so that we can send it to you. Thank you.
Sure, absolutely, we will do that, sir. Thank you again. Once again, we are closing the show.
Thank you. Good night.
Good night, sir. Good night.
Bye,
Good night, sir.
Bye, sir.
Bye, bye for everyone, sir. Bye, bye, sir. Bye. We are closing. Good night, sir.